Bhateja sir, shall we start? Sir, with your permission, shall we start?
Yes, ma'am, we can.
Yes, Pranav sir, we
Yes,
can start now.
yes, sir. A very good morning to one and all. I, Pranav Chipalkatti, on behalf of JSPM's Rajarshi Shahu College of Engineering, Department of Electronics and Telecommunication, heartily welcome you all for the first session of Day 10 of 2 weeks Faculty Development Program on Artificial Intelligence and its application in Biomedical Engineering. Today we have with us an eminent speaker, Dr. to Vikrant Bhateja to deliver session on topic computer-aided analysis of medical images. On behalf of ENTC department, I heartily welcome you, sir. I feel extremely honored to introduce him today. Dr. Vikrant Bhateja is an associate professor in Department of Electronics and Communication Engineering at Sri Ram Swarup Memorial Group of Professional Colleges, SRMGPC Lucknow, and also Dean Academics and IQAC in the same college. He is a doctorate in Electronics and Communication Engineering, which specializes in biomedical imaging with a total academic teaching experience of 17 years, with around 160 publications in reputed international conferences, journals, and online book chapter contributions, out of which 20 papers are published in SCI indexed high impact factor journals. He has been instrumental in chairing and co-chairing around 25 international conferences in India and abroad as publication chair and edited 26 book volumes from Stranger Nature as corresponding co-author and co-editor. He is editor-in-chief of IGI Global, International Journal of Natural Computing and Research, and ACM and DPLP Index Journal since 2017. He has guest edited three special issues in reputed Scopus and SCI Index journals, Evolutionary Intelligence, and Arabian Journal of Science and Engineering under Springer Nature. He has received the Certificate of Outstanding Contribution in Reviewing for year 2016 and 17 respectively in prestigious elsewhere journals like AEUE Measurements, Computer Methods and Programs in Biomedical. He is a senior member of IEEE with Scopus H Index of 24. We are fortunate to have you with us today, sir. I welcome you once again and request you to start the session. Thank you, sir.
Yeah, is the screen visible to everyone?
Yes, sir. Yes, sir.
Okay, am I fairly audible?
Yes, sir.
Okay. So, very good morning, one and all. Uh, Today, I'm here to deliver a session on this topic, computer-aided analysis of medical images, which is a research case study on breast cancer detection. So, the relevance of topic for this session, like we are having this faculty development program on artificial intelligence and its applications in biomedical engineering. So, computer-aided analysis is a very good and well explored area and good enough for interdisciplinary researches as regards computer science engineering or as regards the departments of electronics and telecommunication engineering. So because of this particular pursuit, I have typically selected this particular topic for discussion. And I'm sure with this discussion and case study, all those who are budding researchers or all those who are looking forward for a PhD topic may certainly, if possible, get motivated and start research in this domain. So, just a little about me. These are the areas where I have worked. So, primary one is computer aided analysis of medical images, that is mammograms, MRI, CT scans, ultrasound images. The main agenda had been for early diagnosis of life-threatening diseases. Uh, Other areas in the computer vision and image processing, where I have worked is image filtering, denoising, then signal fidelity assessment, image fusion, and also some works on one-dimensional signals for biomedical signal conditioning, like EEG, ECG, and EMG, along with the application of computational intelligence in medical imaging. So the content resource for my today's session is majorly extracted from a book, which has been published this year only in Springer uh, by the name Nonlinear Filters for Mammogram Enhancement. This is a robust computer-aided analysis framework for early detection of breast cancer. So if anybody after this session may be interested for working in this particular domain, then I think this particular book would be a very first tool for that person. So to have a background, fundamentals, and then to start work in this particular specialized domain. So about the session, uh, we'll be talking about introduction to CAD of breast cancer. Then mammographic image analysis, we'll take an insight into it. Then computer-aided analysis of mammograms, medical image enhancement and the associated challenges, and then the research gaps. Certainly, this research gaps would be a very important module that we'll be taking up over here. Certainly, which is good for framing new problems in this particular domain. Then, if time permits, let's see how much. So we'll be taking up a few case studies. So generally, I try to take at least, since this is a short session, so at least one case study, which will be, a complete case study covering the research problem formulation in this particular domain of breast cancer detection would be taken up in the pursuit of IQ approaches with the results, inferences, and future directions. So let's start the introductory module, that is the introduction to CAD of breast cancer. So before we take a overview on this and coming to the technical aspects, let's first clear few, kind of a background, some fundamental aspects, some biological aspects of this particular disease. So if you talk about breast cancer is one of the most dangerous types of the cancer. See, this is second almost in the number in terms of mortality rate and being dangerous in comparison to the lungs cancer. Now, generally, the targeted women age groups which are in this particular domain, which is affected by this particular disease, is in the age bracket of nearly, say, 35 to 55 years of particular age. So early stages, if you talk about, the disease in itself start originating, say, from younger ages, say around 30 years of the age. But at that particular stage, certainly the symptoms are not visible. So it's a kind of an asymptomatic stage. And as with age, it seems that the tissue densities shrinkes up. So these tumors appears, they seems to get visible. So that is why generally they appear in the form of fully grown tumors or cancers, say after an age of 40 years or 45 years. But certainly at that particular time, since they are now fully grown tumors, so treatments and cures are becoming little difficult. So certainly, the earlier it is treated, the better treatment or medical solutions could be possible over there. But owing to this delay in the process, and in which it appears in any of the screening or diagnostic methodology, this is basically the cause of entire problem. So early detection is the only remedy for such a kind of a cancer, but it is generally not an easy task. So I'll be just showing a couple of images over here, just to have some clarity of biological aspects of this particular subject. So if you see this particular image, this shows some random cells over here, which we call as the initiating parts of the cancer cells. Now, if you see the boundaries of this particular cells are generally perfectly circular, I mean, or oval or whatsoever. So they have a very circumscribed kind of a outline. So initial part, when these cells are there, it's only that these cells are multiplying at a kind of a abnormal rate. But as far as these cells are present delocated, there is no problem as such. Now let's take another view of the same cell. Say after a certain span of time, if we see, then the outer periphery of this particular cell starts getting disturbed, the periphery gets tampered, and we see that there are certain radiating lines, or what we term it biologically as speculations. They start originating from the boundaries. So certainly we say that the malignancy has started, or it has initiated in these particular cells. Now if you see this particular frame, now since these tentacles, these speculations have grown, they tend to attack, or you say merge, with the other nearby cells. So what you now again biologically term this is as, say that the metastasis has started. That means now this malignancy has started spreading to the other cells. So this is how the malignancy spreads from one cell to the other, until a time it gets converted to a grown tumor, and say it starts affecting the particular organ of a body. So this is the basic of this kind of the background, biological background of this tumor. So that's why see, we say that breast cancer is any form of a malignant tumor which is developed in the breast cells. And for the initial screening, the screening modality that we use is mammography for analysis of these breast pathological disorders. Although there are other advanced tools also available, MRI is there, CT scan is there, but generally as regards the screening at a very, very initial stage for a particular patient, generally mammography and ultrasonography are the kind of the initial platforms. Now, mammography has its own disadvantage. Although it is the most common methodology, it is very simplest methodology because it is just a breast X-ray which has been taken, and that to a low dosage X-ray, but it has its own visualization impairments that we'll be talking about. So we sum up here that effective treatment of this particular cancer is rarely possible when these symptoms are visible. That means when we arrive at a symptomatic stage. But certainly, if somehow this treatment could have started at asymptomatic stages, the screening, uh, then certainly the treatments could have been possible. So for adequate and effective treatments, that is why we say that an initial or early detection is mandatory. It's important. And a severe stage, I mean, this tumor being converted to a severe stage can be certainly avoided. So that is why the bottom line is that once you detect it at early stages, certainly, like to a good extent, we are reducing the breast cancer mortality. Now, let's talk about the overview of this system, which we call it computer-aided diagnosis system. That means now how we are applying or interconnecting engineering domain to this particular sphere of medical domain of breast cancer detection. So this is a very, very fundamental basic diagram. I think most of you would be already familiar, all those who have heard similar talks beforehand. So this is the very fundamental diagram for any computer aided diagnosis system, where we have medical images at the input. Then you have a pre-processing stage. Then features extraction is being done from those particular output processed images. Then feature selection is being done. Say the redundant features are dropped, the important features are selected just to speed up the process. And then it is being given to a classifier, which is maybe, certainly a machine learning tool, which acts as a decision making tool as to, classify these images into, I mean, by a automated means into that whether they are harmful or they are not harmful, or they are cancerous or they are non-cancerous. Now, let's go a level higher into, like, let's see if we expand this particular block diagram, and let's have a very modular view of each individual stages. So generally, where we get these images from, so for this, generally the first block in such a system is the medical image acquisition. So if we talk about breast cancer, so for us, the acquisition methodology, the screening methodology over here is mammography, which is, a low dosage X-ray. So since we are not directly taking a X-ray and feeding it to your system, so certainly there are repositories for testing and experiments which are being created by a lot of universities, research centers, and hospitals in India, over as I mean abroad, where we have people have researched on certain images, they have benchmarked results with those images, and they have prepared a repository of such images. So once these images are acquired, say they have prepared a repository of such images, and they have been kept in a database. Now, most of the databases generally, already pre-process images in some way or the other, so that they are directly handy for being used in experiments or simulations by us. But I mean, where and all this particular pre-processing is not done, so maybe at initial stages some pre-filtering or any necessary such kind of, I mean, depending upon how that particular image is acquired, or based on see any basic impairments, some pre-filtering can be introduced. So if you talk about this, so this particular section becomes a pre-processing module. So once we obtain our these mammograms, these breast X-ray images, after pre-processing, now what is required is that we need to enhance these images. Now, certainly, why we require enhancement over here is that these images, when they are acquired, as I told, that the acquisition is from a very low dosed X-ray. Now, why it is a low dosed X-ray? Because certainly breast region is a very sensitive part. So you cannot apply a very strong dose of X-rays to acquire those images. I mean, certainly this particular image is not acquired with that strong dose, which is certainly used for a bone X-ray of your leg, of your hand, or certainly of your spinal cord. So there is a lot difference, and I think the lowest amount of this particular dose is being used for this mammography. So now, since due to the health reasons, security, and safety, we have compromised on the dosage of the X-ray. So, some way or the other, this is going to compromise the quality of the image that we are getting at the end from the system. So, the acquisition of such, mammograms which are being made over here are some way or the other, affected in the form of their visualization, or say in the form of their resolution, or say in the form of their contrast, or say in the form of their sharpness. So, these all basic traits of our image are actually affected, certainly because of this low dosage. And, there are numerous other hardware challenges in the acquisition of the X-ray images. So you require, some kind of a filter or some kind of an algorithm so that, these images are properly enhanced. Now, Enhancement is also done for a normal image. Enhancement is also done for a medical image, but there is a difference. See, you're doing enhancement for a normal image. I mean, the purpose is different. Maybe, you want to beautify the full image. You want to do improvements in brightness, contrast for the full image. Or say, maybe you want to do it, say, for a particular of your face region. Now, as you regards, the enhancement of medical images, certainly we require that the enhancement should be done, say, for the particular region which we are more interested upon. Say, you term it as the region of interest. So that is the purpose of, enhancement. So when we do enhancement for a medical image, certainly the aim is that we want to improve visualization of these particular images. Now, certainly this could be in terms of brightness, contrast, its sharpness, etc., etc. Now, once this image is enhanced, certainly maybe we are trying to pull up with some of the losses which have been there because of the low dosage of the X-ray. Now, once this enhancement is done, that means the contrast is improved, or say the brightness, sharpness is improved. We go in for another module which is known as segmentation. So once all the areas in a particular image are highlighted, they are being enhanced, we go in for segmentation so that the particular region of interest where the more focus of diagnosis is required, more analysis, more investigation is required. So we do segmentation for such images. And once segmentation is done, we are supposed to localize suspicious regions. So at the end of segmentation, we have localized or marked suspicious regions in our medical image, or you say mammographic image over here. So this particular set of blocks that we have talked about over here, they come under the head of detection module. So this is the first most important phase, which sometimes you term it as CAD E, to differentiate with the normal CAD, as CAD is just the kind of a superset over here. So you say CAD E, that is, this is computer aided detection module. So till now your mammography image has just been processed to come up in a, say, better form, into a better visualized form, and your suspicious regions which require further medical investigation or diagnosis are being marked. So till now any AI is not applied over there, just that we have used computer vision or image processing algorithms at that stage, so that your regions, your abnormal regions are marked over here. Now at this point also, certainly we call it computer aided detection, because those suspicious areas are marked in the image. Now once it is marked in the image, now at this particular stage only, a radiologist can certainly intervene over there, or a medical expert can intervene over there to give his or her opinion on the investigated areas. So this is particular the significance of this computer aided detection module. Now what next in this? Now the next is, we go in for, say, suppose, although good enough, now a radiologist or medical expert can intervene at this stage to make a decision as to the whether this image is a normal image, or there is some abnormality which is present in an image. But still it happens, that medical person or a doctor is a human being only, and there are chances of misdiagnosis, there are chances of lack of precisions at times because of a number of reasons. So at times there is a requirement that there should be some artificial intelligence oriented, or you can say some automated decision support system should be now inculcated, so that some way the system also segregates these images based upon the training, based upon the machine learning. Now the system should segregate these images into that either they are cancerous, or they are non-cancerous, or they are normal, or they are abnormal, or whatever be the categories. So over here, the next step comes feature extraction. So certainly, once we have enhanced the mammogram, the suspicious regions are marked after segmentation. Now we do features extraction, that means we extract certain features from those images. Now, definitely, those features, are some mathematical parameters which you are extracting from those images, right? So you should bear in mind that till this stage of computer aided detection, your image, your original mammography or your original medical image has converted to a modified image, to a better image, a better visualized image. But now certainly that from that particular image you have started extracting numbers, you have started extracting digits from those images, because now certainly the things are different, because the you require those digits to be used, those numbers to be used to train a particular system. You have because now you want computers to take decision on that. So definitely it can't be done directly on an image. So certainly feature extraction has to be done, so that useful information or parameters could be extracted. Now certainly when you do features extraction, n number of features are extracted. At times this could be lead to large tally of features which are extracted. Now maybe all features are not very useful. Now certainly it happens that there are redundant features over there. So you have some way or the other, you should have a methodology for feature selection, so that you can pick out the important features, and certainly those can be given to train the machine learning tool over there, train your neural network or SVM or whatever tool you are using over there. Now certainly you may have automated selector tools also, like PCA, LDA, etc. techniques could be used over there to select those features. Now, there may be a requirement that you require a optimization of features also. So you may say apply any form of a AI optimizing technique over there, so that these features can be optimized, and then they can be feed it further for decisioning. So a number of such operations can be done at this particular stage, just so that the purpose is single, the purpose is same, that we want that this classifier may yield an output with much greater accuracy. So once these feature vectors which you obtain at the output of this feature selector are given as input to these classifier. Now this could be a machine learner, this could be a deep learner, right, which could segregate these images into normal, abnormal, cancerous, non-cancerous, or when we say cancerous, it could be benign or malignant. So this kind of classification is done over here. So this particular, these particular stages come under the head of what we call it diagnosis module. So again, to differentiate the nomenclature, you sometimes you see it is being referred to as CAD-X, that is computer aided diagnosis. So there is very fine difference between the two, that is computer aided detection and computer aided diagnosis. So when we say detection, you should remember the entire analysis is done on an image. The image is still an image, just it is a better form of an image, or say the suspicious regions are marked on that medical image, where the judgment is ready to be made by a medical expert. Now if we do further automated analysis on such images, so that now the computers, right, now your tools are automatically classifying those images on their own, right, based on the self diagnosis, based on the training which is being given to those machines, right. So that particular module is known as a computer aided diagnosis module. But certainly see, this is ultimately a machine, this is ultimately a AI tool. AI tools are trained by us only, it is trained by human only. So ultimately you can't 100% rely on these particular tools. So they are just kind of a second opinion devices second opinion devices over here, second opinion criteria over here, so that just the radiologist can validate their decision further, as to like whether they have taken the decision in a more accurate manner or not. So that is the sole purpose ultimately, because it happens at times that on paper such classifiers give you accuracy as 100%, but once you validate your results with a doctor, maybe the doctor says that the results are not appropriate. So that is, the certain reason where, this diagnosis fails also at some places. So what is most important is, a very good correlation, a very good handshaking is expected between these two. I mean, the responses which are being given by these classifiers, and, the responses which have been given by the doctors or the medical experts over here. Because then only, because based on those responses, based on these feedbacks, you certainly go and retrain these classifiers in a better manner with better amount of features, right? So that, more accurate responses could be there, or more clearly we should say that, the responses are more close to that of, what has been made by a radiologist or a doctor. Now, if as a researcher or, as a PhD scholar, somebody, prefers to take up this problem, then if you go and explore, then, you will get, I mean, a very, very vast literature on this particular subject. Now, if you pick up the most of the papers, say in last 5 years or say in last 10 years, you'll come across that, most of the research is being, focused nowadays towards development of, the AI tool over here, applying deep learning to, to improve the accuracy of the system. That's good enough, certainly. But, when you see those papers repeatedly, you see as if, most of the work is already being done over there. You rarely see something new coming up over there. I mean, you see that people are cascading the classifiers over there one after the other to improve the response, or you are cascading some optimizer with your classifier to improve the response. You are using different feature extraction techniques to improve the response of the classifier, or at times maybe you have extracted a lot of features, so you are using some optimizers for features, you are using good feature selectors over there. So all those sort of kind of domains are there where you find different works and different problems which have been framed and research is published in this particular domain. But some way there are certain areas which are not very well explored if you check out. Now the point is that most of the works you see, I mean, the focus has been to improve the entire CAD system, right? Which could be little difficult. So certainly, if somebody goes back and explore it module by module, like as I have told, so you should just see that there is a lot of research which is yet to be done in each and every module. Now try and think about it, what I'm saying. Listen, see, you may use the best of feature extraction techniques, you may use the best of feature selection techniques, you may use the best of optimizers or classifiers. But ultimately, if a particular suspicious region is wrongly marked, or you say that the tumor region is not clearly visible, then certainly this entire effort which is being made in developing this decision making tool goes futile. Why? Because certainly the images are not properly visualized. The areas, the suspicious areas, the way they should have been explored, the way they should have been visible to extract or to provide the diagnostic information, certainly they are not in that manner. So if you just go back and dig into, you see that you see a particular paper, the approach is that you get an image from a database, you apply the basic functions of enhancement, right? Edge detection, which has been available in the libraries of your MATLAB or Python, right? You apply those functions over there, you enhance those images, and then the whole work is just focused on just to if somebody has done ANN, somebody has used SPM, let's combine the two responses, let's now remove it and apply a deep learner over there. Certainly somebody's accuracy is 92%, let's now improve it to 95% and let's now publish a paper. So all this exercise would be futile if you think in the manner that your particular region or your particular diagnosis is, I mean, your particular organ is not visualized better after enhancement. So, lot of scope of work is there if somebody focuses on the domain of enhancement, if somebody focuses on the domain of segmentation itself, right? Because very less you can say filters are developed, or you can say more specialization, more sophistication is required to develop filters in this domain, because maybe whatever filters are developed, they focus on certain types of images, certain types of abnormalities, but there are very less solutions over here where one filter or one enhancement solution could be uniformly applied to n number of different cases, right? So enhancement module is a particular module which require a refocus. Segmentation module is again a module which require refocus. So certainly focusing to improve these filters, right? Focusing to improve the responses of these filters are, itself a independent problem, complete research problem to work upon. Another part, people just go by conventional databases which are being present over there. No doubt, it is very good, because certainly if you want to compare the results at the end of this analysis, you need to benchmark them for a good publication. So definitely those benchmarking databases are important, because they are the one which are being used from, say, last two particular decades for trying and testing the work. So you have to use those images, no doubt. But certainly focus should be from here on, to dig out new cases of, say, breast cancer detection or any other type of, uh, anomaly in the images. And that could be, only possible if, certainly when starting research in this particular domain, you go and collaborate with some oncologist or some radiologist, because then only it is possible. You can get live real-time cases to apply your image processing, your computer revision, or your AI on those particular images, and then test what outcomes are given by your system. Certainly they could be compared in parallel to what diagnosis is being made by the doctor. So that is a kind of a very, very good real-time kind of a way to do research in this particular domain. And then they are actually the new problems, the new kind of disease variants in those images, and that becomes an independent case study, say, for a research or a research publication. So that is why I just elaborated upon this different aspects of this module. As if you look in a focused way to a particular module, then each particular module is itself an independent research problem. So we, I mean, conclude over here with this in this topic that CAD-E and CAD-X are two spheres under the head of CAD, right? So one is detection and one is diagnosis. And generally diagnosis is something which is, improving or validating the response of the detection. So just what we have discussed, let's see numerical, this illustration of this, what we have studied right now. So suppose we say that we have acquired an image. So say this is a breast mammogram which has been acquired, an X-ray image, or say it has been readily taken from a database. We say that we go in for a pre-processing. So say some pre-processing has been done. So if you see this particular aspect over here, the image you say has been say just color transformed over here. So maybe this appears to be a little colored image. This has now converted to a black and white image. So this could be one form of a pre-processing which is being done. Now, say then the enhancement has done. So say the image has been enhanced. The region or the tumorous region or the diagnostic region has been more focused over here, right? And then see, we have segmentated. That means after segmentation, what has happened? This particular region of interest has been segregated from the rest of the image for, say, a more focused analysis, or say a more focused kind of a diagnosis. So this was, the first phase, what you term it as the computer aided detection system. Now coming to the second phase over here. So this was the detected region of interest. Now from this region of interest, different features could be extracted. So suppose if we extract textural features, so they could be mean, standard deviation, contrast, correlation, energy, homogeneity. So these different features are taken from these images. Now maybe all these features may not be very important. There could be certain features which are redundant. So say we have selected some of the features. Now certainly this selection could be made manually also, or this selection could be made in an automated manner also through some algorithm. So say we have taken some of the selected features over here. So this is what is our phase of feature selection. Now, mean, contrast, correlation, homogeneity, all these are numbers, all these are values. So say we have prepared a feature vector over here after feature selection, and this feature vector can be given to the classification or a classifier stage to yield a final decision whether to classify the image into, say, whether it is a benign kind of a tumor, or it is a malignant kind of a tumor, or it is a cancerous image, or it is a non-cancerous image. So this is, the particular phase of computer-aided diagnosis. So this is how, these images look like. Say in the beginning, this is the image. Say after particular enhancement, and say once the regions are being marked. So this is, you can say, a manual marking is there, and over here the markings are being made by the machine or the tool over there. Now let's come to the next module, that is the mammographic image analysis and insight. So as I already told you, that this is a breast X-ray which employs low doses. And if you see these doses, then over here, then the lowest certain dose is used for mammography in comparison to the other parts of the body. Then again, it's a low dosage, simple X-ray one. So it's a relatively inexpensive examination, and that's why, most popular modality for initial screening of the breast cancer. So when this particular image is acquired, this image is acquired in two different views. One is known as the oblique view, where the acquisition is made diagonally. This is known as MLO view. Another is known as the CC view, that is your craniocaudal view, where the acquisition is made from the top. So generally, whenever mammography is performed, so two such images are being acquired. The purpose is that at times it happens that tumors are visible in one particular view, but at times they are not visible in another particular view. So that is why taking acquiring images in this particular two views are just to provide us variety in our analysis. So if you talk about the limitations of this mammography acquisition system, so as we have already discussed, that generally because of the low dose of the X-ray, you have poor illumination is there, noise levels are therefore high over there. So generally the mammographic image which has been acquired, it is having low value of SNR. So we say that owing to the performances constraints in the X-ray detector, your mammographic images are generally affected by the contrast, SNR, and spatial resolution. So these three properties are primarily affected when we acquire a mammogram. So we can correlate from here that if we go in to do enhancement of this particular image, so now you can understand that this could not be just done by a single enhancement or a very simple of your conventional enhancement techniques, right? Because the focus when you're going to improve these images visually, it has to be made on the contrast of these images. Some way, when you are improving the contrast of these images, you have to check out that your signal to noise ratios are not getting affected over there, because sometimes when you try to improve the contrast, you want to enhance the contrast, you want to amplify the contrast, you are not aware that at the back end your noise has amplified, your background noise has amplified over there. So you have to keep a close check on the signal to noise ratios and also the spatial resolution. So some way or the other, you have to keep a check that while improving the contrast, the sharpness of your image is also duly maintained. So that is why these mammograms are among the difficult radiological images which are to be interpreted by the radiologist, and you require really skilled set of experts for these images. And that is why there is a need, there is a significance of these second opinion tools like CAD. I mean, people like that these computer assistance is given to these radiologists or medical experts, so that certainly they make very accurate or precise decisions. Now, let's have a quick view at the types of mammograms. So if we see that there are different types of mammograms which are being shown over here. So it shows you that somewhere the density of the mammograms is very high, the tissue density is very high, you can see. And over here, the tissue density is very negligible. Here you see the tissue density is very minimal, or it is, you say that it is a scattered tissues are over there. So some way, your tissue density has a big role in, along with the kind of enhancement technique that you will be applying over there. Because if you see, the more dense the tissues are, so you see that there is a dense cloud of tissues over there. So these tissues are white. So if at the background the tumor is present, then tumor is also white. So because of this camouflaging effect, it may be very difficult to visualize a tumor in this particular image. Although if you have images of this kind, right, where the background tissues are very less, or they are scattered, then it is very, very easy to visualize the tumorous or the affected regions over here. So certainly, higher the tissue density, more difficult it becomes to analyze that mammogram, more difficult it becomes to enhance that particular mammogram, because you need to have a very, very sophisticated kind of an enhancement technique for that purpose. So over here, this variation of tissue density is actually proportional to the age of the patient. So it is, these dense tissues are there when you have early ages of the patient, let's say somewhere towards the age of 30, and say these are the mammograms which are generally in the age bracket of say 40 to 50. So that is why it happens that why we say that under the age group of 40 to 50, these tumors gets visible, the tumors gets diagnosed, because certainly at that particular time, the tissue density in the background in these images, they get so minimal that it gets very, very easy to find out them. So this is just a categorization, how you segregate a normal mammogram you can see over here. So this is a benign mass, as I already told you, that when there is exactly circular periphery of the tumorous region, it is less tend to affect the other regions, so it is a benign tumor. When there are distortions in the boundaries of these tumors, we say that malignancy has started initiating in that particular tumorous region, and it could be harmful, or it has more chances to get converted to a cancerous cancer at later stage. So we say that why this mammogram analysis is generally complex. So as we have already discussed, this complexity is due to the density of the tissues. So once the tissues are more dense, you can see the two dense mammograms over there. Then, as I told you, that these abnormalities, these tumors are, camouflaged in this white background. So it becomes very, very difficult to, detect tumors when the mammograms are very, very dense. So generally, that is why when you surf literature on, say, the enhancement problems of mammograms, you may now check out that, generally you'll find out very few papers who have, picked up the cases of dense mammograms, right? I mean, the mammogram cases where the tissue density is dense and then applied their enhancement technique, right? Because certainly it is where the enhancement techniques tends to deteriorate the performance when the tissue densities are becoming very, very dense over there. So generally, this is one focused area in this particular domain, that if you really want to, improve, or you want to develop some enhancement technique for this particular mammograms, or then certainly you should try to pick up the cases, or you should try to, analyze the results on the dense mammograms. Now, similarly, even when there are fatty mammograms, we should not forget that, this is a 2D image, right? So at times there are overlapping of the tissues also, there are overlapping of the abnormalities also. So at times it happens, you see one phase of the abnormality from this view, but at times maybe at the back end some another abnormality is present, which may be overshadowed due to the presence of another abnormality. So they are also the pretty cases. So at times the fatty mammograms are also not very simple at times to analyze. So just you can say a comparison over here, that under fatty mammograms it is relatively easier to detect tumors in comparison to the dense mammogram. Now, another, big challenge in mammogram enhancement, right, or computer aided analysis of mammograms, is basically the subtlety of breast abnormalities. Like right now, we have been just naming it by a very, very common term, that is tumor. But actually or biologically, these tumors are, specifically as regards to mammograms, they are classified into varieties by the radiologist or your oncologist. And each type has a different role. Each type is, representing a different phase of a disease or a different stage of the cancer. So, again, if you focus upon enhancement, then, maybe your technique could focus on visualization of certain types of these tumors or abnormalities, but it's rare to cover the entire spectrum of abnormalities that are being present over there. Or say you have picked up a database, so certainly your medical database is maybe having four types of different breast abnormalities categories. So you have trained your AI tool basically for images with those four types of abnormalities. So it is for sure that, I mean, as far as your database is concerned, you're getting 98% accuracy or you're getting 100% accuracy. But maybe if I give an image which is having fifth or sixth or some another type of abnormality over here, then there are very, shared heavy chances of misdiagnosis, or, false positives could be generated over there, because ultimately, your system may not be trained for those category of tumors. So one such category of tumor is known as a mammographic mass, or you call it a lesion. So these are, grown-up tumors. They are appearing as dense regions, and at times they are camouflaged under the glandular tissues, which makes their segmentation difficult. So these are now, say, the different categories of mammographic masses, or you call them mammographic lesions. So if you see, I think now you are familiar with the first two categories. If you see the first category, you can see a very circumscribed periphery of the tumor. So we say that, this particular kind of, when the borders are very, very circumscribed, very, very defined, you see that these cancers or tumors are really harmful. So we say that they are your kind of benign or likely to be your benign masses. Now there is another category which is speculated. So if you see, there there are tamperings in the border, the radiating lines, speculations are visible over there, and these speculations mark your malignancy. So once these speculations are there, certainly your mass or your tumor is malignant in nature. Now, the problem is not just restricted to being benign or malignant. Now the problem is that you have certainly a third category also. Now, this third category is, if you have a look, then at times it is very difficult to, categorize whether this is, your benign kind of a abnormality or this is your malignant kind of a abnormality. So, say that is the case of your ill-defined masses which are being present over there. So, at times if you are designing, say, a kind of a AI tool which is classifying your anomalies into benign or malignant, then certainly this category creates problem. So certainly this is a third category which require emphasis now, and you can't categorize this particular one into, say, categorically benign or categorically malignant. Certainly this category is the category which needs further investigation. Now, this is the category which you can't call it to be a normal one, which you also can't call it to be a benign one, but certainly it can be marked as a category which is desirous of further investigation and analysis, and the final decision to be given by the doctor or the medical expert. So, you see that these tumors or these masses, they even grow in different phases. So when they're growing in different phases, they're changing their shapes. So you can see, as it is being visible over here, that the earlier stages where the periphery is very defined, they are benign. The later stages where the border gets tampered or the speculations arise, they are your malignant, right? But again, you see there is one intermittent stage over here, right, where you say that the border starts getting deteriorated. So certainly this particular case, you can neither classify benign or you can classify malignant, but it says that this is a very suspectable case which could later be converted to a tumor. So this is actually the variation of malignancies with size and shapes of anomalies, which actually makes these analysis difficult. Why? Because you need to have an enhancement algorithm which can visualize each type of abnormality. You need to have such feature extractors with you which are covering these different subtleties, these different variants of your masses. So this is the areas which require deep focus when you are working in such problems. Now another thing, if we see this particular area, now in this particular zone, it appears like this is just a tissue density which is present over here. Now suppose if I focus on this particular area more, or if I enhance this particular area, then suppose the enhanced version appears to be this. Now this is not certainly a tumor. This is not certainly a mass. But you see that this is a very ordered collection of white dots which are being present over there. So these clustering of white dots which has been present over there, they are actually tiny specks of calcium deposits which are being termed as microcalcifications. Now, if we talk about microcalcification, they are actually the early predictors of this particular breast tumors or breast cancer. These are the most earliest stages. Why? Because actually the tumor growing starts from here. There is, say, collection of this tiny specks of calcium. They are initially scattered. Maybe through time they get clustered, and once the clustering becomes dense, they get converted into masses. But at times, there are biological consequences where this clustering, if is not very strong, or you say that the nearest antibodies are very strong, then this particular clustering also gets dislocates, and this set of calciums again dissolves and disappears. So there are chances that the such clusterings could be malignant. There are chances that such clusterings could be benign also. So again, masses, tumors is one category, but detection of calcifications is also one separate aspect for detection of breast cancer. So you can have a view, and generally, if you refer the cases of the younger woman, then generally they are more prone to, full tumors are not available in such cases. So generally, what you observe in such cases are these tiny specks of calcium deposits, which could be the initial predictors for this breast cancer. So generally, we see that why you require very skilled radiologist over here. There is difficulty in interpretation by radiologists, even because of lot of biological aspects which we have discovered. There are technical constraints also, and as a onset, you have higher incidence of unnecessary biopsies also, which are being done because of that. Now, biopsy is a kind of a very painful process. It's a very invasive process where if some misdiagnosis has been done, and say tumor which is which could have been likely benign, it has been misdiagnosed as a malignant one, then certainly at a stage it could be recommended by a doctor to go in for, say, FNAC, that is a fine needle aspiration cytology, that is this biopsy. So what is being done over there? Say a needle is inserted into that particular area, the flesh is being taken out. Now you can understand the degree of discomfort, the degree of trauma, the degree of pain which has been involved over there, and then that has been analyzed under a microscope for further analysis. Now, maybe after analysis it comes out that that area is not affected and it is benign. But what is the for the person who has undergone that particular trauma, that particular pain? Now, secondly, now that you have visualized that particular area under the microscope now, and you have said that it is benign, but now you have tampered that area with a needle. Now maybe certainly that could have caused to initiate metastasis in the nearby tissues. So maybe what area was actually a benign one, just because of false diagnosis it has been misdiagnosed as a malignant tumor, and because of biopsy now actually metastasis has started over there. So you can understand that this is the background cause. What is the level where this misdiagnosis can take patients to, right? So therefore, there is a strong urge, there is a strong requirement of such computer-aided diagnosis tools. So that is why we go in for computer-aided analysis of mammograms, where on the screen these images are analyzed, different image processing operators are applied there and then, so that these images can be better visualized to make diagnosis by the radiologist. So over here, once we talk about computer-aided analysis, the aspect comes which we have discussed a lot by now, that is the visualization of a particular mammogram, or visualization of, say, a particular region of interest. So it is where comes the medical image enhancement or your mammographic image enhancement into being. So that is why for a good computer-aided analysis system, you need to have a strong mammographic image enhancement system and the background. So now let's come to the next aspect over here, that is the challenges which are being associated with the medical image enhancement. Enhancement, maybe most of us are aware, but when we apply that enhancement to medical image, there are a lot of trade-offs, there are a lot of challenges, and it is actually bridging of these challenges, the compromise between these challenges, is actually made when you develop a particular algorithm for or filter for enhancement of these images. So if we talk about image enhancement primarily focus on improvement in contrast of the image. And when we say image contrast is fundamentally defined as the difference between the maximum and the minimum pixel intensity of a particular image. So you can have a look that this is an original image and this is the enhanced image. So improving this difference between the maximum and minimum pixel intensity means that at the back end, when you're doing this, means that you are improving the contrast of your image. Now, when we say image enhancement, it is not just about improving the contrast of the image, but it also to improve the sharpness of the image. We also want that the necessary edges, the necessary boundaries should be also properly visible. It should have due sharpness over there. So, there comes the role that, not only the contrast, but the edges of the images should be also very clearly visualized. Why? So now you correlate it with a medical image, that when we talk about edges, what is the role of the edges? Because it is only the boundaries of these tumors, the edges of these tumors are, predictors for the stage of the cancer. The speculations which are being arising, they are the predictors of malignancy. So certainly not just contrast, but sharpness or edges should be also very clearly visualized. So when we say image enhancement, you have another aspect also. One is contrast enhancement and the another is edge enhancement. So one is focusing to improve the contrast of the particular region. Another is focusing upon to improve the sharpness of that particular region. Now, what is important over here is that when you carry out image enhancement, we should not forget two things over here. Now, the two things are that number one, you are not just providing that image for machine vision. That same image is also there for a medical expert to give its decision, right? So we have to keep in mind that it is not that our aim is to just enhance those images, collect features and give it to a machine vision tool or a computer, your say machine learner tool over there. Our aim is also that your image should be enhanced in a better manner so that a human viewer, a medical expert, should visualize that particular image and give its decision. So there is one concept which, at times when we are applying image enhancement, we are missing it. So I have just bringing it to the notice that this particular concept is being known as HVS, that is the human vision system or human visual system, because it happens that most of the enhancement techniques which are being designed or developed, it happens that they suffer from this particular anomaly, that their visual responses are not correlated with the human vision response or the human visual system. So it is always desirable that, to develop such enhancement approaches where the responses given by that enhancement algorithm are duly correlated with that of the human vision. So how we correlate these two things? So there is a very small concept in the background that if we visualize the, our beginning chapters of our any image processing book, we talk about, the human eye and the aspects. So generally, that area is often skipped by us because we just consider it to be a theoretical area as regards image processing, right? But the challenge is that if you focus upon the science or the principle with which the image is formed on the retina, you find out that there is a logarithmic relationship in the image formation model by which the intensity is being mapped at the retina for a particular object. So since logarithmic relationship over here relates to a non-linearity or a non-linear relationship. This gives, a kind of impetus that if you are using a non-linear enhancement algorithm, certainly it is expected that the responses of visualization are going to be correlated with that of the human vision system. And it is for this reason that, even the same concept of non-linearity is being introduced in different types of display devices as well. Now let's talk about medical image enhancement. So how it is different from conventional image enhancement, because uh, if you talk about conventional image enhancement algorithms, they may not give good results or satisfactory outcomes on medical images, because the reason being these medical images are having different types of background. I have shown you that the background tissues are varying greatly from patient to patient, from age group to age group. So definitely when the background of the image is varying in such a manner, you may not just apply any conventional image processing algorithm over there. Now, second problem is this, that if you unevenly apply a complete, say, fundamental algorithm on a particular image, then what happens that in lieu to enhance the contrast of that image, at times it happens that the noise component gets enhanced in those images. So you wanted to enhance the contrast, but actually the noise is also enhanced, right? Which results in, say, over brightness or a kind of unpleasant visualization in those images. So this is the problem when you apply just conventional image enhancement algorithms outrightly to the medical images. Now, what we expect in these medical images as that there should be some mathematical algorithms which should focus to improve the visualization of medical images so that there is better visualization of the diagnostic features, like what we are aiming to diagnose information from. And these enhancements should identify the morphological changes. Morphological changes means changes in the structure of the tumor, changes in the shape of the tumor. So all these kind of things are very easily discernible or visualized when you say that you should have a ideal medical image enhancement algorithm. So another part, that this should not be accompanied by undesired artifacts. That means it should not, enhance the noise during, improving your image. So just this is just a figure over here. If you see that this is the original mammogram over here, maybe you have applied some conventional algorithm. Then conventional algorithm, you see that the noise, this image is not very well visualized, or it nearly appears to be the similar kind of a image. But over here, if you see, the things are little brighter. So maybe here the enhancement is much better. Now, another part. When we now focus upon mammographic image enhancement, what we expect from a ideal algorithm. So our ideal visualization is that your mammographic image enhancement algorithm should improve the contrast between region of interest and its background. So at times, if you consider this full image, this full background, it may be a problem. But if we focus that this is our tumor region, then we should say that this is our, say, foreground, and this immediate is your background. So now you have to improve the contrast, you have to improve the difference of pixels with respect to background only, your immediate background only. So, I mean, if you apply an enhancement algorithm in the first case, now since you have a huge background, maybe your results are not very, very good. But over here, you are improving this particular region by, with respect to its immediate background, which is, a small region, So maybe in that case, this particular algorithm may give better results because you have taken a lesser background over there. So this is, the first important aspect which you should have clear in mind, that it should be, possessed by a mammographic image enhancement algorithm. Now, another part is that the lesion edges or the edges of the tumor should be sharp. So if you see that this is the original mammogram, this is your original region of interest, fine. But if you see over here, we have done enhancement, say this kind of image is obtained. So over here, the contrast is not very well improved with respect to the background. Now over here, the contrast is improved, but the sharpness is not very, very well over here. But if you see the last image over here, according to our requirement, this is the perfect image over there. Now, why this is the perfect image over here? Because your foreground region is very clearly visible over here. Also, very sharply, you can see these radiations, these speculations from the boundary are also very, very clearly visible. So over here, your mammographic image enhancement algorithm has improved the foreground with respect to the background, and secondly, the sharpness is also improved. Now, beyond this, if you compare this image to this image and this image, you'll find a major difference. Certainly, the major difference is not because the enhancement algorithm is very good. The major difference is because if you see over here, there is one more aspect which is present, and that is known as, say, background suppression. The background is suppressed in this area. So now here comes the concept of simultaneous contrast, because at times when you have the background and foreground of similar intensities, it causes camouflaging over there. So if you want to reduce that effect, so you just can't go in to improve the contrast of your foreground region, because certainly that is going to enhance the noise in that system. So what is the solution? The solution is that you improve the foreground to a limited, to a certain extent only, but you also try to suppress the background. So at times, when you start suppressing the background, with respect to that background, the foreground itself becomes better visualized. So that is what has been taken care, that you are getting a very, very different and a very, very better segmented and visualized image in the last particular image that I have shown you. So we see that if a particular mammographic image enhancement has been done in an ideal or this desired manner, then we tend to overcome these ailments which have been introduced by the X-ray system, and also we are improving the spatial resolution problem of these mammograms. So when we say mammogram enhancement over here, right now we are focusing upon two parameters over here. That means we are enhancing the contrast over here, and we are also enhancing the edges over here. Now, this is another example over here, like what we have mentioned earlier, that when there is enhancement of these medical images or mammograms, right, at times when you are enhancing the foreground too much, it causes amplification of unwanted noise. Now, what is actually this unwanted noise? Now, please don't confuse it with the noise which you see with the kind of salt and pepper noise, dotted noise, or you can see some Gaussian noise or some colored noise. Please bear in mind, this is not that noise. And when you say amplification of noise, it is actually, see, because of this over enhancement, what has happened? Your tumor region, right, it has become over brightened. So it is actually this over brightened, this over saturation of brightness is actually known as your amplification of unwanted noise. Technically, you also define it as overshoots in the image. So when you say that there are a lot of overshoots in the image, that means these are the region of excessive brightness which have been caused due to the over enhancement of that particular image. So we have to bear one thing in mind, that when you are enhancing the contrast, you are enhancing the edges, you should not forget that you have to control this aspect, because in times to improve the contrast, to improve the edges, your noise gets enhanced, then it spoils the show. Now, another thing, that suppose if we want to, remove this particular noise, then over here, at times noise removal may also cause the blurring of details. So if you see over here, there is lot of blurring of details, lack of sharpness when you try to reduce noise. Now, so let's come to a more sophisticated definition of mammogram enhancement. So when we say mammogram enhancement, we say there is enhancement of contrast, there is enhancement of edges, that means your details should be sharp, plus there is a third aspect now added, that is there should be noise smoothing or noise suppression also. So when you say mammogram contrast enhancement, actually your algorithm should be performing these three tasks, or these three tasks are so combined that you are having a mammogram enhancement algorithm. That is why I say that if you just focus on this part of enhancement, then actually this becomes a complete big problem, big research problem for analysis, right? Now comes another trade-off, because I mean, when you combine these three things, that is enhancement of contrast, enhancement of edges, and noise smoothing, when you combine these three things together, there are also trade-offs which are associated. So if we see over here, there are two types of trade-offs which are associated, and it is actually balancing of these two trade-offs which which is the integral part of any of your mammogram enhancement problem. Now, what are these two trade-offs? First of all is there is a compromise or trade-off between noise smoothing and contrast improvement, because if you try to improve the contrast in a much better manner, at times it may cause over brightness. So if you improve contrast beyond a particular limit, it can cause over brightness or overshoots or noise. So this is one trade-off. Now another trade-off is that at times, if you want to balance this noise smoothing over there, right? So you want to improve upon the SNR. So if you want to balance this noise smoothing, at times it affects the preservation of edges and details over there. So what happens, that when you want to control this noise over here, at times it affects your edges and resulting in lack of sharpness over there, right? Let us see how this is being shown visually. If you see, then this is the first trade-off, how this is visible. Say this is your original region of interest, and say this is your enhanced region of interest. And if you see over here that this is your contrast enhancement constraint or trade-off, that over here you try to enhance it a lot. Certainly it has enhanced. You can see with respect to background, things are better visible, but you see that there is a patch of over brightness now in the foreground region, which you call it overshoots. So noise amplification has entered over there. Now let's see the another aspect over there. Now suppose you want to reduce this noise, then what may happen? This may affect the sharpness of that particular region. Like ultimately, earlier you see these speculations are sharply visible. Now you see that this sharpness has got disturbed over. So this is your second constraint or second trade-off, which I have told, that is your edge enhancement constraint. So now we come to a much better and a practical definition of enhancement, or you say medical image enhancement, that it should be noise controlled. This term is highlighted over here. It should be noise controlled contrast and edge enhancement. So another challenge is that you rarely have any generic technique for mammogram enhancement, because, as I told you, you have different types of lesions, you have different types of calcifications which are present over there, and visualization of dense mammograms is also very, very difficult. So again, having develop an algorithm, which is good to the dense mammograms, which is good to, all the different types of abnormalities, or, which is good enough to visualize the calcification, is a challenge. So you can see one example over here, that again, this is one image. Again, by a normal view, you cannot predict anything. Let's have a focused view over here. Say this is your region of interest, but again, you can't predict much in this image. Say suppose we have carried out enhancement. Now you can see that certain dots are visible over here. So gives you an impression that calcifications are present over there. But now what has happened? Suppose you want to improve the contrast more. Now what happened? This over brightness has come. That means your noise, or what you call overshoots, have come in this region. So whatever visualization was there in that region, that has also got disturbed. So this is another challenge, that developing a generic technique for different types of abnormalities, for calcifications also, for different varying background tissues also, it's again a problem. Now, one big issue again, which if you can understand, then certainly, this is itself a focused domain of research, right? Now, what happens? Suppose I'm dealing with your conventional images. So when we are dealing with very conventional images, what happens? Suppose we have a original image. Now say noise has been added or superimposed in this image, right? Or, during some process, it has been affected by noise, right? Now, suppose I have applied some filter or some algorithm to restore this particular image. Now, suppose I want to calculate what is the improvement in quality. I want to numerically assess what is the degree of improvement in quality. So a very simple logic, a very simple mathematics that incurs over there is that I'm just going to compare this particular image with this image. So comparing these two images means this is the restored image. That was your original ideal image. So as a reference, you compare it, right? So say that was, say, your 100%. That restoration has come out to be 80%. So that means you get up some numerical figure of merit over here, say suppose 0.812. So that means certainly the restoration has been 80% only. So there is approximately 20%, which is the loss of quality or some loss of features which are there. Good enough. Now, just have a look at these two images. Now they are your medical images, or they are your mammograms. Now this is your original mammogram. Now when this is your original mammogram, you know that this was not a good image. Why? Because you have a lot of challenges with the X-ray system. You have low dosage of the X-rays over there. So you have this as a poor contrast image. The brightness was not good. The spatial resolution was not good. And also the signal to noise ratio was also low in these images. Now I have, say, applied some enhancement algorithm and I get this particular image. So once I apply an enhancement algorithm and I have got this image, now how should I calculate or estimate its improvement in quality? Now, as per my previous procedure, if I compare this image with this image, actually I'm not doing justice. Why? Because now this image is actually your better image by your initial reference image. So your reference is inferior, and certainly your obtained or your processed image is superior now. So this is a very big, conceptual challenge, which, most of the people at times ignore or don't focus on. And, you apply same types of quality parameters, same type of figure of merits to the medical images, which is a big no over here, because certainly you will get a value, because say it is garbage in, garbage out. So you apply that algorithm, certainly it will not say it is NaN or it is infinity or something. It will give you some value, but you will be very depressed to see that that the values are not favorable. Why? You see that the response is very good. Certainly this image looks very good, but if you calculate the figure of merit by the old criteria, then certainly your figure of merit is not going to give you a good response over here. So you will be always confused that why it is happening. Why it is happening is you are using the wrong thing at the wrong place. So that is why when we focus on these medical images and when we use figure of merits for these medical images, it is always recommended to go in for those kind of figure of merits which are not dependent on any reference. I mean, that should be some absolute numerical indices where one value could be calculated for this image, one value could be calculated for this image, and then certainly you can compare that first value is lower, second value is higher, so the response is better. Also, maybe when you are dealing with one type of abnormality, then what is happening? Maybe one index is giving you good response. But maybe if you talk about, say, different kind of modality or different kind of images over there, maybe that particular quality index or figure of merit is not able to give you good response over there. So that means by the changing scenarios, by changing modalities, by changing images, at times it is to be focused that are you using the right figure of merit over there, because 50% it happens that researchers are working on the right algo, they are getting the right kind of visualization, but only because of the incorrect choice of the figure of merit, they are not getting a correlated result over there. So this is again a very good aspect. If focused, then selecting a dedicated problem or to develop a figure of merit for a particular set of medical images is again an independent problem of research. So coming to the research gaps now. So if you talk about research gaps over here, so very well research gap is this, that the enhancement response should be always correlated with that of the human visual system characteristics. So that means whenever you are using a particular enhancement algorithm, you always have to check back that are the responsible responses are in favor of the human vision system. So that is only possible when you're going to validate those parameters when we do research. Our research is only limited to that. Say, suppose you have applied your algorithm, you have applied your figure of merit, and your figure of merit is giving you a very good value, 0.85, zero point 0.9 or something, or 90%, and you get happy that say good enough, my task is achieved. But it's still no, because ultimately if the end user is not satisfied with the quality of that image, certainly this entire exercise remains futile. So an important aspect when you do research in the domain of medical images, that you have to be cautious of the fact that the algorithm you select should be the one which is expected to be HVS correlate, or you see that you have to check back or validate that the responses are also correlated with the human vision system. Another thing, now that is enhancement approach operates without a prior knowledge of ROI on mammogram. Now, when you are generally referring to databases, what happens? I told you that those images are generally pre-processed. They are the benchmarked images. The suspicious regions are already marked in those images. So, say for initial training, for initial simulations, it's very good, right? It's good for you to, you know the abnormality is there, you have applied your algorithm over there, and then say you are getting the response. But is my algorithm or my enhancement filter, is it giving, a very good response for an unknown kind of an image? Then certainly this is a big challenge. This is a thing which is worth, investigative, that say if I get a new image altogether where the abnormality is not marked, where there is no prior knowledge of the region of interest, right? And that too the image is of poor contrast, is my enhancement algorithm able to give a good result? So again, that is a challenge. Then another thing, generalization of enhancement operation. Because as I told you, when you see the literature, when you see the published works, generally, if you focus on the results, you'll see that only very few set of sample images are shown, or they are experimented upon. Or rather, you say that the complicated cases are not very well shown over there or demonstrated over there. So, I mean, what is required is to develop such a kind of enhancement algorithm whereas, there is generalization of enhancement operation. That means that, the your enhancement algorithm should be customized to different types of breast background tissues. So as I told you that, see, there were 5 different categories of mammograms on the basis of the different types of tissues. So your enhancement algorithm should be so customized, right, that it can give results on the fatty or fatty glandular mammogram images also, and also on the dense or heterogeneously dense images. Then it is something worth or contributive, right? So another part, that the correlation between the two should be there. That means you shouldn't have to change your algorithm much for that purpose. With minimal tuning, with minimal complexity, you should be able to address different category of mammograms under the shade of a single algorithm or a single enhancement tool. That is most important. Another research gap is that the contrast enhancement and the edge enhancement constraints. Like the two trade-offs, the two constraints that we have learned is that in the view to enhance the constraint, enhance the contrast, the noise may get amplified, right? And secondly, in the view to suppress that noise, your sharpness may get affected, or your edges may get blurred. So I mean, it seems very easy to understand and illustrate, but again, applying it with right set of mathematical operators or right set of filters, when you go to that depth, it is actually a very, very big problem. So when an enhancement problem is being selected, it has to be so customized that it is able to overcome the contrast and the edge enhancement constraints. Another part is, that is your, say, figure of merit. So that is that you cannot have a generalized figure of merit which you say is applicable to all set of medical images. So certainly, the based on the nature of tissues, based on the nature of the image, based on the kind of diagnosis you are doing, you have a different figure of merit for a different aspect, for a different type of quality assessment that you are focusing. So you cannot just generalize signal fidelity criteria. So when you are developing such algorithms, when you are developing such filters, so you have to be very cautious on the choice of the figure of merit. Because maybe you say that I'm developing, say, some enhancement algorithm for different types of medical images, and you keep calculating the PSNR all the time, or you keep calculating the mean absolute error all the time, then certainly you may not get a coherent result at all places, certainly. So that is a big thing to be focused, because we develop a very good algorithm, enhancement or something, or a filter, and then we compromise and we'll just pick up some simple metrics to validate it, which is not a good criteria. You should try to perceive that what all aspects of image improvement that you have incurred, that many parameters should be evaluated from the aspect of figure of merit. So if I am improving the contrast, if I am improving the sharpness, or if I am improving the signal to noise ratio, then certainly I should have a figure of merit that should validate, or that should evaluate, the degree of contrast improvement, the degree of sharpness improvement, the degree of improvement in the noise, all those factors. Or certainly, if I don't have such a universal metric, then at least I should pick up, say, combination of 4 or 5 metrics over there. That is, say, one to address one feature, another figure of merit to address another feature, another figure of merit to address another feature. So this is what is the case. And another research gap is, that is to extend the analysis to the real cases. That means we should just not limit our analysis to the cases which have been just given by the these medical imaging databases, because that is just a limited pool which has been assembled, studied, and used for research. So in view to develop better problems with much exploration, much extension, then you should pick up new cases, analyze them with your algorithm, and certainly each case according to me, each such case according to me, will become an independent case study. So again, if you think of extending your work on real cases, then itself, it becomes a big new chapter of this particular research problem. So generally, if you talk about medical images, then these are the different fundamental image processing approaches which are known to us. Histogram based approach, unsharp masking based approach, or non-linear filters, or multi-resolution processing approaches like wavelets and controllers. So these are all fundamental image processing approaches. So if you say that you apply these approaches directly to the medical images, certainly the results may not be very pleasant all the time. But if you think on, say, mathematically going to the back end of these algorithms, going to the back end of these filters, improving these approaches, improving these algorithms, so that they are able to figure out, customize, to overcome the constraints which have been told so far, then certainly all these approaches which I have mentioned over here, they can be customized and applied for every type of medical imaging problem. I mean, you can customize your unsharp masking to be applied for mammogram enhancement also. You can customize this unsharp masking for being applied to MRI image enhancement also. Similarly, if you talk about your normal histogram based equalization, it may not be very well, giving you results. I mean, it may be giving you results for your images, right? Your standard images. But if you apply it to medical images, maybe it's not giving you very good results over there. But certainly, if you try to improve these approaches, if you try to customize these approaches mathematically, or by, say, addition of additional parameters, so that you overcome the challenges that has been told so far, then certainly histogram equalization could be applied with improvement of parameters, with improvement of its functions, to different types of medical images as well. Same is the case of your non-linear filters also, right? With non-linear filters, like these filters are like your quadratic filters or your cubic filters or your polynomial filters. So, since there is a term which is being associated over there by the name of non-linearity, so, that non-linearity aspect motivates that, if you apply such approaches to these medical images, certainly the responses are going to be very, very coherent. The responses are going to be very, very improved in response to the human visual system. So that is why, such non-linear filters are a preferred choice from HVS point of concept. Another one is your multi-resolution processing, where you have set of decomposition filter banks with wavelets, contourlets. Like, so with these filter banks, you are decomposing an image. You are decomposing an image into, say, different types of bands. Say you have a low frequency band, you have a high frequency band. Now maybe there are certain features of your medical image that are visible in the low frequency band. Maybe there are certain distinct features, they are being visible in the high frequency band. So if you treat them differently, maybe you get a better solution. Like, say, suppose take an example of your mammographic images. So if you decompose it with the wavelets, what happens? You have a low frequency band, you have a high frequency band over there, right? So when you have low frequency band over there, low frequency band contains all those parameters which are generally focusing towards the contrast or brightness of that image. When you focus upon the high frequency band is encompassing all those parameters which are pertaining to the edges or pertaining to the sharpness of the image. So you have segregated your image in frequency domain, right, in transform domain, into two different bands now. So now you should know that if you want to improve the contrast part, that contrast improvement should be carried out on the low frequency band. If you want to improve the edges, you can apply it to the high frequency band. So certainly this may overcome the earlier constraints of these two problems, that is your contrast enhancement constraints and edge enhancement constraint, that can be overcome over there. And then finally again you recombine them, right? You apply these inverse transformation and you get back the final image, which could be again a better and an enhanced image over there. So these approaches when these approaches are going to be customized, so that it overcomes the constraints which have been told so far, I mean, these could be very well applied to the medical image. So don't think from that angle that histogram equalization or unsharp masking is a very, very fundamental approach. Actually, they are very, very fundamental approaches, but once, depending upon the need of application, they are being customized, they are tending to give very, very good results, right? So I think we have to limit the session till here. So we can take up the queries.
Yes. I now request Dr. Sakshi Paithane ma'am to take up the QA session. Ma'am?
Am I audible?
Yes, ma'am.
Yes. Okay. Good morning, sir.
Good morning,
So
ma'am.
this is Paithane madam. So can we proceed for question answer session, sir?
Yeah, sure, ma'am.
So the first question is related to risks about the X-rays. So repeated X-rays can increase the risk of breast cancer. Is it true, sir?
Yeah, it's very true. And this is the reason why you go in for a very low dose of X-ray is being kept over there. Secondly, the problem is that we say that early detection is a solution, but early detection doesn't means that when no symptoms are visible. At times, if general screening is being done, so no doubt you have been earlier informed that there are anomalies over there, you are devoid of, you are de-stressed that you are not having any problem. But certainly it happens that if that particular X-ray upon bombardment over there may because of those ionizing radiations, it may affect certain of the tissues over there. So maybe at that tissue level, if you observe, then say malignancy or you can say metastasis may start in certain cells, and maybe what was benign till today may again get cancerous at later stages.
Thank you, sir. So can we say that repeated mammography should not be done?
We should not. Again, it is being
As
done.
a regular checkup.
Not I mean, unless it is being recommended by somebody specialized, so it is to be done then only. And then secondly, it is being done after a certain intervals only, not always. So certainly if the results are not very clear in the mammography, then rather than getting it done for a second round of mammography too early, I mean, the results may be supplemented with other imaging modalities like ultrasonography, just to complement and have other information which may not be present in the mammograms.
Yes, sir. Okay, thank you, sir. The next question is related with the gene expression utilization. So is it possible to detect breast cancer at early stage by using gene expression analysis or mammography?
See, this could be, a very new kind of a aspect, which could be experimented. As right now, I have not come across such works on this. Maybe a specialized domain for someone. So gene expressions are different for, different types of traits. So definitely it could be well experimented on this because, for different kinds of abnormalities, for different kinds of cases, the gene expressions may be different. So this could be, one domain to explore that particular problem. Yes, next question.
So we have one question. Can we analyze EEG signals in the form of images?
Yeah, it happens. I mean, it depends, what type of database you are having. So both ways it is possible that you can analyze them as images. So if you analyze them as images, you are taking it in the form of two-dimensional image processing. If those databases available to you in the form of vectors, then you can apply the same algorithms in single-dimensional image processing. So both are, workable. But
Thank
again,
you,
visualization could be there. This image part is only good enough for the part of visualization, but for as regards other aspects of signal conditioning are concerned, it is better to restrict it in the form of single dimension image processing, single dimensional signal processing only.
Thank you, sir. So all this what we discussed is related to the 2D mammogram.
Yeah, this is related to 2D mammogram. If you have a 3D image analysis over there, then ultimately again you have different sections of those images. So if there are visualization challenges there also, then there also these techniques can be very well applied over there.
Thank you, sir. So next question is related with the progress of CAD. So what is the status or progress of CAD in actual application? So whether the medical fraternity is approaching towards it in a positive way?
Well, definitely, it is approaching in a positive way. See, again, it depends from individual to individual also, because what happens, like somebody who are very old in this field, maybe they are not very computer savvy, so they are not very acceptable for these kind of things. But all those who have been embarked towards the new research about the new technology, then they are more accepting to this kind of thing. Secondly, that was the aspect, as regards your oncologists are concerned. But as regards your radiologists, they have been now exposed to, new type of techniques live analysis, computer aided analysis, right, where they can directly analyze those images on the screen over there. So that is a very welcoming domain for this purpose.
Thank you, sir. So with this, we are at the end of question answer session. Thank you very much, sir. I, Dr. Sakshi Patel, propose vote of thanks to Dr. Vikrant sir for accepting the invitation on behalf of Rajarshi Shahu College of Engineering. Thank you very much, sir. Thank you, sir, for sharing valuable information about mammogram and CAD. So also thank you for detailing the research gap in this domain. Thank you very much, sir.
My pleasure. And I must say that you can share my email ID with the participants. So if anybody has any further queries, we can get connected offline for that purpose.
Yes, sir. Definitely, sir.
Thank you so much. Thank you for offering this platform. Again, second time I have been a part of your college for this FDP session. So it's a great pleasure to be here. Thank you so much.
Thank you, sir. Thank you, sir.
Hello.
Yes, ma'am.
Harpale ma'am, good afternoon.
Hello. Madam, join झालेला नाही दिसत आहेत, madam. Yes, she's there. Harpale madam, good morning. Hello.
Yes, ma'am.
Make her co-host.
Yeah, just a minute.
Yes.
Yeah.
Yes, ma'am. Yes, ma'am.
Yeah.
Yes, ma'am. Please check. Hello, ma'am. Now you can unmute yourself.
The voice is a bit low. Yeah.
Yes, yes, ma'am.
No, ma'am. The voice is very low. Yes, ma'am.
So am I audible now?
Yes, ma'am. Yes, ma'am. So, shall we start with your permission, ma'am?
Just give me 1 second. Yes, sir. We can start.
Okay, just a minute. A very good morning to one and all. I, Pranav Chipalkatti, on behalf of JSPM's Rajarshi Shahu College of Engineering, Department of Electronics and Telecommunication, heartily welcome you all for the second session of Day 10 of 2 weeks Faculty Development Program on Artificial Intelligence and its applications in Biomedical Engineering. Today we have with us an eminent speaker, Dr. Varsha Harpale ma'am, to deliver session on topic Brain Seizure Prediction. On behalf of E&S department, I heartily welcome you, ma'am. I feel extremely honored to introduce her today. Dr. Varsha Harpale completed her PhD in ENTC in specialization of biomedical signal processing. She is presently working as an associate dean quality assurance and an associate professor at Pimpri Chinchwad College of Engineering, Nigadi, Pune. She has a total of 20 years of teaching experience and 1 year industrial experience. Her areas of interest are biomedical engineering, signal processing, and embedded systems. She has association with professional bodies like IST, VSI, and IEEE. Speaking of her achievements, she was a finalist for the state level Avishkar competition in 2018 and has bagged two Best Paper awards. Uh, Speaking of her research contributions, her book is in process by publication by elsewhere on the topic brain seizure detection and classification using EEG signals. She has published a book of applied statistics in research methodology, a practical and scientific approach by CRC Press publication in 2019. She is the associate editor of International Journal of Advanced Engineering and Technology. She has coordinated EPG PEX, that is an online PG project conference under the aegis of Board of Studies ENTC SPP. She was a track chair for Health and Hygiene International Conference on Computing, Communication, Control and Automation 2019. She was a resource speaker for the topic Biomedical Signal Processing Case Study and Advanced Papers Searching for Effective Literature Survey. She is a reviewer for International Journal of Biomedical Signal Processing and Control by Springer and International Conference on Sensor Networks and Signal Processing SNSP by Shi University of Science and Technology, China. She has, to her credit, two copyrights registered and has published one patent. She has a total of 30 publications, 2 SCI, 15 Scopus, and 13 others. We are fortunate to have you with us, ma'am, today. I welcome you once again and request you to start the session. Thank you.
Thank you, Pranam sir, for such a nice introduction. So thank you RSU and AICT for giving me this opportunity to share my research work with the community who is interested in the medical engineering research. My area is about biomedical signal processing, so I will be discussing my research area and that same things, that is the brain seizure prediction. Just let me share my screen. Give me 1 minute. Sir, is my screen is visible to you?
Yes, ma'am. So, ma'am, we are hearing a bit noise while you're talking. So, could you?
Is it okay now?
No. Could you take the mic away from you, because I think it's.
Okay. Just give me 1 minute. It is actually having a
Yes.
camera mic and my headphone mic issue. Just give me
Okay. Okay. Yeah. Yeah.
Okay, am I audible clearly now?
Yes, ma'am. You're
Okay,
audible
thank you
clearly.
so much. So, very good morning to all of you. It's a very interesting area that I would like to talk on. That is about seizure detection, prediction, and classification using EEG signals. So, these are my contents. Brain research areas in brain analysis. I'll little talk on to this brain analysis, and then we'll go in the detail of the topic by means of EEG analysis, and we will understand how we can use EEG signals for the seizure detection, seizure prediction, and seizure classifications. So, research areas in brain analysis. If we analyze the research, engineering research that is conducted in last 4 decades, we could understand most of the people are working in the medical field or medical biomedical signal analysis based research. In this case, one of the research area is about a brain analysis, and this brain analysis is having a various research challenges where the engineering researchers should work, and still they need to they are having a great opportunity to come up with some good solutions that will be helpful to the doctors as well as the patients that they are suffering from various neurological disorders. So research trends in brain analysis, if we identify, the brain disease detection and prediction is one of the area where researchers used to work. Human emotion analysis is also one of the part that is, now you might be knowing about the teenagers. They are mostly prone towards the what we can say, some suicide or some of the migraine, some of the stress related issues. So if we could identify this human emotions and we can provide some good solutions to that, that will be really helpful to this teenagers community. Next is about motion tracking, then automated detections of neurological events. Along with these are very basic areas, but what we can say that to the specific areas that we can identify, that is about emerging research demands and early detection of brain disorders. Now, basic, when we look forward for the brain analysis, either we'll go with the brain imaging or we'll go with the EEG signals, so that is signal processing. So when we look forward for these two methods, we identify that the brain gives us the electronic signals or these image information that is very random, non-stationary, and prediction of any patient prone to the brain disorder. It's a biggest challenge. So early detection of brain disorder stands for you need to identify that particular patient is prone to certain neurological disorders, and if we could able to identify that, we could able to provide some solutions so that the particular patient will not go into will not land up into these kind of disorders. So this is one of the area. Next area that we can say, you all of you know that whenever we look for MRI or functional MRI, EEG measurement systems, these all systems will only record your information. They will only read and record your information. So they just have the facility of read and record. Now, when we go to some rural areas, the machines are available, but the expertise in the field of analyzing these signals or these images are not there. So, if we could provide some engineering solution as advanced tools in the brain analysis, we could provide that to the various rural area sections, and we could able to come up with certain basic, or you can say the initial level of conclusion, and then the particular patient can be taken further for the further analysis sort of things. So that is about advanced tools requirements in the brain analysis. Simple architectures for brain signal analysis is the same, that if you can generate certain architecture which can be appended as a hardware to the existing measurement system, that machineries that are available in this area will definitely improve. So we should come up with certain architectures that can be disease oriented, they can be generalized, okay, and that research point we can take up and can come up with certain solutions. Next is about brain machine interfaces, BMIs. You know, various BMI researches are going on. The next and very important about a brain stimulator. You all of you know about the pacemakers. What this heart related pacemaker used to do it is, if certain person is going with some random or some irregularity in the heart operation, the pacemaker provide exactly reverse what you can say signals to the heart, and it is nullifying that abnormality and making your heart to work normally. So this is what is pacemakers. So same sort of stimulators. This is also one type of stimulator. So same sort of stimulators are also required whenever a certain patient is in very, what you can say, emergency based situation. In that case, we should come up with certain stimulator which can help that patient to normalize his life and can behavior with his body. So brain stimulator is a very recent area in which this engineering research should go on. Okay, but it's very difficult task actually. Some of the people have already started working on to stimulators and have come up with certain patents and certain research. So we can also think of how we can build some electronic system that can be planted in a brain, which can work as a stimulator for certain high rated diseases. So I would like to proceed further with the neurological disorders that is observed in a human, what you can say, in the overall crowd or population of the world. That is, I'm explaining this neurological disorders with the help of WHO report, which is published in 2015. So if we look forward for this, we will find that normally we underestimate this neurological disorders. We normally ignore this neurological disorders when we are looking forward for any research or any medications. Okay, so we need to understand that there is a biggest need of taking this neurological disorders very seriously in engineering as well as the medical what I can say research, and providing some good solution to simplify the life of the population. So the WHO states that over 30 million people that suffers from the neurological disorders. So it is also projected that it is going to increase. Just give me one second. I would like to change the view. So here, what we can say, is projected by WHO 2015 that the neurological disorders are going to increase with a rate of 12% from 2005 to 2030. So still there is an alarming condition where we should work and have tried to control or try to provide some good solutions where this rate will start decreasing. It's a predictive value of the 12%, but we can reduce it if we could provide a good solutions in the this particular what we can say this particular years. So if we compare the neurological disorders with the other prone diseases like tuberculosis, AIDS, malaria, or any heart diseases or respiratory diseases, you find it at that neurological disorders has a highest rate of DAL. Well, this is a death adjusted life cycles. Okay, life years actually. When you look forward for neurological disorder, death is one of the issue. Whereas, sorry, it's not death, it's disability. Disability adjusted life years. This is what we call a DALY. The neurological disorders are not curable mostly, and because of that the patient need to live with these diseases for a longer time till their death. Okay, so it's not the thing that immediately whenever the particular patient will suffer by neurological disorders he will be having a death in some duration. This will not be like that, but the person need to live with this disability for the longer period of his life. So what we need to do it is we need to provide some support to make that life easier or simpler. Okay. So by WHO, it says that 6.3% of global burden that carries by neurological disorders. So we should work on it and should give some solutions. I will take a help of one more WHO report that is published in 2008. Just give me 1 second. Hello, sir. Is my Excel sheet is visible?
Yes, ma'am.
Okay. So, it might be. Sorry, it is having some. This is the Excel sheet which is released by the WHO organization, and it's in April 2011. But the report of this is released. Initial report of this is released in 2008. That's why it's mentioned that. But the Excel sheet that is released in 2011. So if you look forward, they have enlisted all the what we can say diseases that is observed as per the global burden of the diseases is analyzed. So if you see this sheet, you could find it out that various neurological disorders. I cannot mention. I don't know whether it is visible to you or not. That tabs that is mentioned in the Excel sheet. It's a death rate for the 0 to 14 age. This is the age given from 0 to 14. This Excel sheet is open for the age group of 0 to 14 years. So if you look forward, the neurological disorders that you will find out it is having a rate of 16.6 in India. This is a country-wide statistics that is they have released about, and in India we will find it as 16.6% of overall death are because of the 16 because of the neurological disorders, and out of which if I look forward for epilepsy, the 14.4 of the death are because of the epilepsy. Okay, I will be highlighting epilepsy in this research discussion. That's why I am just mentioning you this epilepsy report. If you look forward for the next age group, that is about from 15 to 59 years, in this ages also you will find out a huge count of neurological disorders of 74.8% in India. You could find that it will be having a highest rate of what we can say death because of this. It's not directly because of disorder, but it's because of the disorders. So epilepsy, again, if you find it out, it's 37.3% of overall burden that you will find out in this age group. And next is about in a case of 60 plus. In 60 plus also, you will be finding out 50.9% is the neurological disorders rate along with the epilepsy of 9.9%. So we can say that in India also this neurological disorders having a highest impact. We should not ignore that impact, and we should support this suffering community for a good life. So if I'll compare this with the pie chart, this first pie chart is about the death rate and the second pie chart is about the disability rate. In first pie chart, you could identify that because of the death rate, you could find, or you can say, if you compare this death, exactly opposite I said, sorry. The first pie chart is for disability adjusted life cycles, and second pie chart is for the death. Okay, so disability, if you find it out, the stroke has a highest impact onto this patient's life, or you can say neurological patients mostly belongs to the strokes. And if you find a death rate of it, it's the highest one. And because of this only, most of the engineers in the last 5 decades have already worked with the strokes and come up with the good solutions. But still, stroke is a disease which will not be curable, which will not be, what we can say, we cannot support much to improve the life of the patients. Next is about migraine, this Alzheimer, epilepsy, then we'll have some nervous system related cancers. These are also some of the, what we can say, diseases that can categorize in a neurological disorders. When we'll go for the death, Alzheimer disease, this disease is normally identified after 60 plus, and you know that most of the people used to die because of this Alzheimer disease. They used to have an age group more than 60%. So epilepsy also has one impact, okay, and we can work in that. Again, in epilepsy, lots of work is going on. I will suggest that what can be the area that can be taken up in neurological disorders in the next slide. So if I'll take a survey of the IEEE publications from 1960 to 2018, we identify that most of the research, engineering research, I'm fully talking about engineering research. Most of the engineering research is done in the area of the strokes and stress. Okay, and you'll find out every now and then you'll find some good solutions that will be come up in the area of the strokes and stress. But there is some one more area where epilepsy, Alzheimer, and depression has a sufficient engineering research done in that area. And why, where we require to work now? We require to work in the marginal area and the needy area of this neurological disease, where the marginal engineering research is required in Parkinson, brain tumor, brain injury, and spinal cord injuries. I am only talking on the basis of publications that is in between 1960 to 2018. So we can discuss about the cerebral palsy, autism spectral disorders, sclerosis, migraine, and dystonia. Now, cerebral palsy is also one of the diseases where the people will not die, but they have to live with the disability. And because of the neurological behavior of that particular patient. So we can have various, what we can say, research areas in this neurological disorders, and we have a good scope to work with to provide a good solutions to the patients and doctors. So various methods that are there, if you look forward for brain signal analysis, that are EEG, MEGs, fMRI, then NIRS, PET scan, SPECT, ESI. So any of the method you can choose it. And now the selection of the method that will be specifically depend on to the disease that you are analyzing on. Okay, so whatever your disease that you are analyzing, we need to consult the medical practitioners for that particular disease, and we need to identify that what method they refer to identify the patient in the particular disease, and that method can be taken up as an analysis method for the brain related disorders. So I will be from this particular list, I'll be addressing a EEG. So my rest of the research slides will talk on to the EEG specifically. Why EEG? Because EEG is a cheap solutions that is available, but it's not. It might be cheap as sort of a setup available, but it is having a huge data complexity. So it is. If I look forward for this chart, which is a comparison chart for it, it is having a good spatial resolution, and it is having a medium temporal resolution is one of the reason for which the EEG is selected or MEG is selected for the brain analysis. Okay, if I'm talking about epilepsy, but if I need to go for the cancer related things, I will be understanding cancer by locating that particular thing, not only by EEG, but I need to go for fMRI. So as I said, as per the disease, we have to select the method is the first criteria of selection, and second criteria is for that particular disease, what are the method available, and from that method, which is the best suitable for me. So that can be the one of the criteria for the selection. So the advantages of EEG over the other method, it's actually a non-invasive method that I have taken, but it has invasive also. That is, the needles will be inserted in the brain and the signals will be recorded with the help of the needles. But that is criteria, or that is the advantage of non-invasive method. It has good spatial and motor temporal resolutions. So thus we can go with the good, or it also provides a good dynamics of the brain processes. When we look forward for brain diseases, this special location of disease oriented part of the brain, identification of that is one of the challenge. So if you use a multiple sensor on the EEG sensor on your head, in that case, we could able to find out affected area of our brain by that disease. Okay, so that's why EEG can be one of the method that you can take it for the neurological disorders. So I will talk specifically on to the EEG signal processing and its analysis. I hope I'm okay with till this point. So EEG, you know that there is a 1020 standard that is released by what we can say, the it's a well understood standard that is recommended by the brain. You can take into consideration and can work for that. Okay, so this is what is the way the sensors are placed onto your scalp, and we can work on identifying it. But challenges in EEG signals, they are very small in amplitude. Okay, is one of the thing. Next is about specificity, that the location of the affected area of the brain is one of the thing that we have to go for. So specificity, sensitivity to the noise, artifacts in daily life. When you blink your eyes, that is also having impact in your EEG signals. So we need to what we can say, separate this blinking from the any EEG signals if you would like to analyze it for the diseases. Kind of handheld devices, okay, or a smaller devices, or having less sensors, or we can say we can have only 3 to 4 sensor identify the location of affected area of a brain, and just implant that particular sensors around that part of the brain, and then these sensors can be connected to the system with the various wireless approaches. So that is the thing where we can also work. Okay, so now I would like to tell you about how these EEG signals are measured or recorded. This is your brain. Okay, just give me 1 second. So we have already seen that it is divided into this part-wise sections, and each of this section will be responsible for certain of what you can say the functionality of the human body. And these are all connected with the various neurons. Okay, you know the what is the role of gray matter, white matter. I'll not into that. But each of these EEG signals is basically recording the activity of this neuron, and these neurons are placed in such a fashion that they are what we can say placed in our brain in these kind of column positions, and these columns are called cortical columns, and these cortical columns will behave as per the functionality or as per the section of the brain. So if I'll represent this column, what we can say as per engineering model, if I'll show this vertical column or a cortical column, it can be shown like this. Okay, so you can show this particular as this. So this is what is useful for us to make behavior of brain analogous to the engineering model. Okay, so whatever you are sensing, okay, it might be some excitatory actions, it might be inhibitory actions. These are all sensed by your neurons. Okay, these neurons are connected with the thalamus, and that will be accumulated as an averager. Okay, and these averagers will be giving the appropriate signals to the respective cortical column. Okay, so these cortical columns then responsible for the action related to the sensors information. Okay, and now this model is very helpful for us to record the EEGs, right? So we will be going on to only this cortical column where we are actually related about when we are saying it's about a EEG. So that's why here you could see that this cortical column, okay, having this channel, each of this will be having a separate channel, and you could connect this separate channel with the help of these sensors, right? So we will be having a EEG sensors, you know what are the constructions and all. So these EEG sensors will be recorded, okay, so and it will be giving it to your EEG measurement equipment, and that we are referring about electroencephalography, that is about the EEG. I would like to highlight this box, okay, with the second box that is mentioned the lower side. It says that whatever your action related, or you can say the emotions or whatever your sensory things that will be there here in the input signals, your brain will identify by taking it certain delay that this is what we can say proposed by engineer, that this will not be sensed immediately. It will take certain time, which will be very less, and that's why this delay model comes in a picture. And your brain system always will take this EEG signals, and then it will come down to the average information, and this average information is actually responsible for generating an action related to the sensors. Now this averaging information we are taking by a single channel, and it is given it to the particular electronic system, that what we call it as the processing system. So we'll provide certain gains, certain filtering, and then certain sampling, and thus the digital EEG that is available for us, and we could able to go on analyze these EEG signals for various diseases, right? So this way we could able to go on, what we can say, understand the concept of how EEG will be recorded, because until unless you not understand the concept, it will be difficult for us to work with the signal. So that is what is a thing that we have to always consider for the signal. Now, when we look forward for EEG, EEG can be find out with the two different categories. It's not type of EEG, it is potential generated by EEG I'm talking about. So excitatory postsynaptic potential is one, and secondly is inhibitory postsynaptic potential. So EPSP is basically when we are taking certain input by our sensory organs, and reaction to that is what we call it as excitatory postsynaptic potential, which is generated, and this EPSP normally has a amplitude related things or information like this. Okay, to generate certain action potential, we need to go with the peak of this in a microvolts. Okay, you could see. And when we look for the inhibitory postsynaptic potential means your eye blinking, okay, whatever daily habits that you have, that are called inhibitory, and that potential is always having a very small, what you can say, time width. Okay, and also it will be having a very certain, what we can say, certain or a fixed sort of potentials that we can consider for the analysis. And what is this potential, these excitatory and inhibitory portion will definitely help us to extract this information from the UG signals. So firstly, you find out if a normal person is having this information like this, and how abnormal portion is per patient is to have this information. Both the thing you can use it as an information or a feature and can work with the analysis. Okay. Next is about, once we'll get this, we will be definitely going for EEG signal pre-processing, because anti-analyst will not separate information from the EEG signals. You cannot able to come down to certain conclusion. So let's first separate the information. So I have used, as I said, that I'll be talking on to epilepsy, seizures, non-epileptic seizures in the further sites. So here I have used a data set which is Androsic data sets. This is having a 5 patients. Each of the patients files are 100 files for each of the patients with 23.6 seconds of timing duration and 173.5 hertz of sampling. The same sort of information you could find out in a CHB MIT, where I have used 20 patients. The data set is for 23 patients, but I have only used it for 20 patients. Okay. That is why, because rest of the 3 patient was not having a big duration. So that's why I have only used a 20 patients. So next is about TUH. This is Temple University Hospital. And this data set is not available on a net. You need to request to these by sending your proposal. Then there is to give access to this part. Okay. And nobody till now, you just search a paper. This is very newly introduced data set in epilepsy. The people who would like to work in epilepsy, and then they can definitely use take advantage of this data. It's a very huge data set having 700 plus patients information, where 2000 plus files that are available, more than 5 hours of recording with the 400 hertz sampling. You could find it as the biggest data set now is available. I don't know how it is available readily or with the proposal. Initially it was available with the proposal, and now I have verified all these work with the non-labeled real-time database, which was provided by Dr. Amit Kumar Pandey. He's working as a neurologist, and the data that he have provided, that was with a great sampling of 2000 hertz sampling. So you could identify, when I'm saying the sampling, the data complexity goes on increasing. 173.5 hertz has only 173.4 max samples in a 1 seconds. Whereas if I'll reach to 2000, in 1 seconds, I'll be having 2000 samples available for me for analysis. Obviously, data will go towards more accurate conclusion, but it will take more time for the processing. So very first thing that we have to do it is, we have to extract the power noise, though that can be done by the filtering. Okay, you can choose a good order of filter, and you could able to come up with the filtering of that. Okay, so you could see that if I use a order filter, notch filter is used for the channel 10, and I could able to reduce, remove the noise, power noise from it. Right, the last figure, it is having, now see, you will find a glitch here. Let me search my cursor. So glitch that will be removed here, and you could able to find that glitch is overcome, and you can come up with the normal averaging data for the part. Now the next part is about artifact removals. You can use a various artifact removals methods that are available. You just go and finding out what is the best suitable that I found. It is about the ICA, independent component analysis. You can easily separate information using independent component analysis. All are very much aware about the ICA. So we can remove the blinking if artifacts, we can remove chewing artifacts from the part, and you can come up with the separated information from these artifacts and your other than artifacts EEG signals, and that can be used. Next is about, now you know that it's a time-based signal. Continuously the signal will be reaching it to us, and it's a non-stationary. So as it's a non-stationary random signal, it's not possible for us to analyze the full signal of 4 hours or 3 hours. So what is the best choice for us is about going into windowing of that signal, right? So here the windowing is a better solution for EEG signals, and that's why we can go for that windowing. It can be simple successive non-overlapping windowing technique or overlapping windowing techniques. You can use a rectangular window or you can use the Hanning window for EEG signal processing. You choose it. I found it better to work with the rectangular window, right? So that is what is done. And after doing a windowing, we have done the timing analysis, frequency analysis separately, and then we done with the time and frequency analysis. Okay, and this can come up with some good results for the provided research. So now I'll come down to the topic of epilepsy and seizures, where you can say epilepsy is a central nervous system disorder in which brain activity becomes abnormal, causing a seizures of period of unusual behavior, sensations, and sometimes loss of awareness. Anyone can develop the epilepsy. The sentence of this means that you might have experienced that whenever you have a high fever, in certain case, it's like with the certain of small duration you find some hike in your brain. Okay, you find that अचानक से मेरा ब्रेन के एक पॉइंट में बहुत जोर से दुख रहा है, that is also a seizure. Okay, and that seizure we call it as absence seizure. Okay, but that will not be directly a epilepsy. It's one type of what we can say seizure that can occur with your brain. So every person in a life at least might have a seizure once. It might be of different type, but for fever, whoever have come across this fever and all, so they normally have a absence seizure sort of things. So epilepsy affects both males as well as females with all the races. Okay, and with the all ages. You have seen a Excel sheet that I've shown from the 0 age to 60 plus age, all people used to have the epilepsy. There is no specific age group for which what we can say the people are suffering from. Okay, so need of research in seizure is all. You've seen that epilepsy is because of seizure. But normally what happened, any person who is suffering from the seizure used to go to any neurologist. Okay, it might be not neurologist directly, but any doctor. Okay, so neurologists have a specific information. They will definitely not go. I am not having any what we can say contradictory sentence to make on that. But I just would like to say that whenever any person has a seizure, the first and foremost approach comes up that he is suffering from the epilepsy, and that's why the doctors used to give them anti-epileptic drugs, and which is actually having an impact on their rest of the behavior or rest of the life. Okay, so to avoid this unnecessary approach or unnecessary doses of the anti-epileptic drug, the best thing that you need to do it is classify the seizures. Okay, so there are two types of seizures that normally observe. That's what we call a psychogenic non-epileptic seizures that are because of you might be feeling a fits are because of the stress. These stress related fits are called psychogenic non-epileptic seizures. Okay, so we need to have these things. Okay, these are without characteristics of electrical discharges, whereas epilepsy is with the electrical discharges. Okay, so epileptic seizures are due to disruption of electrical activity in the brain, whereas a psychogenic seizure is a psychogenic activity. They are because of the psychological impact of or condition of the brain. So that's why we can provide certain good solution for classification, and can like suggest a doctor that this particular is not a epileptic, so don't recommend a anti-epileptic drug. So seizures are basically it's observed or it's also called as electrical storms because of the electrical disruptions. This a certain part of the brain get affected and come up with the high peaks of your amplitude. If I'll talk into the engineering amplitude oriented parameters. So it will be characterized by actual period of EEG signals. Various tools that are observed, as I've already discussed. EEG is simplest one, that's why it's used in my research. Symptoms, that is period of blackout of confused memory, occasional fainting spells that we normally see, episodes of blank staring, okay, in children. Normally children used to stare without listening anything, without responding anything. The sudden falls on a no apparent reasons, the episodes of blinkings or chewing at appropriate times, missed medications. This is because of the missed medication, stresses or anxieties, dehydrations, or lack of the sleep. So sleep is important, guys. You should go always take a good sleep. Seizure detection. Now I will go towards my topic as mentioned in the schedule is about the seizure prediction. Okay. So seizure detection. Very firstly, I'll talk on to the seizure detection. What I did is about, before going for that, we'll talk on to the challenges, detection accuracy, prediction of seizures, classification of seizures, and psychogenic non-epileptic seizures detections. Classifications basically from seizure, epileptic seizures and non-epileptic seizure. Now, very important factor in this is prediction of seizures. Now, prediction of seizure means I am not doing a prediction of finding out that patient is prone to seizures or not. No, as I said, the patient who is suffering from seizure need to live with the disability of the seizure. So, prediction of seizure means if I could be able to alarm that patient that you are going to come up with certain seizure after 5 minutes or 10 minutes, that patient will be ready to bear with that seizures, or he could take some medicine to smoothen the effect of, or to can say reduce the effect of the seizure. If he is driving a car, he'll take the car aside and he will be ready for the seizure that would be coming up, right? That is what is the significance of this prediction seizure, where I have mentioned over here. It's not that you are finding out कि 10 साल के बाद आपको seizure होने वाला है, or it's not that that what we call early detection of the seizures. This will not be possible at all. Okay, so this is the these are the challenges that what we can take up. Okay, I've worked with the methodology that I've adopted for the seizure detection is I've taken the data set. The features are extracted with the various methods like time and frequency method, spectral analysis by AMD, and then hybridization of TFD and AMD, and then I've given to the machine learning approach of classifier using Nevis multi-class or J48. These are very recent. Okay, so that's why there is no as such selection that I have used for the classifiers. I have got the good results with this. These are very non-linear, so you can come up with the new deep learning method also for these analysis, but I'm talking about feature extraction, feature selections, and classifications. Okay, so feature extractor, there are various features, near about 100 plus features are available for EEG. I'm only mentioning where I found a little impact as per the epilepsy behavior. The feature selection method I've used is the hypothesis method, and this is what is ANOVA. We can go on finding out similarity between the two by considering a normal and abnormal reference, and based on to that you could select the features where these are the certain features that are mentioned as, and that will help me to construct my feature vector, and I've used it for the further classifications. So next is about a wavelet. Okay, so I've used a wavelet, and we know that whenever we are looking forward for DWT, we always go on finding out the separating or filtering out that into the various bands. And for EEG, we have to come up with the 5 bands: gamma, beta, alpha, theta, and delta. And each of this band is responsible for the various human activity. Okay, so you can take that as per the information that is mentioned for these bands. You can find out the impact of these bands onto the certain disease, and you can choose it. I'll be showing you that why I've taken a beta and gamma. Feature extracted, again, as I said, there are 100 plus features. These are the certain features that I've enlisted over here. Again, I've used a feature selected ANOVA, selection method ANOVA, and the final feature selecteds are mentioned here at the last set, and from which I've constructed again a feature vector for the wavelet kind of thing. Okay, you could see that if I'm having a seizure, the amplitude of the gamma and beta, it ranges between the minus 100 or minus 1000 to 1000. Okay, whereas if I'll go with the normal EEG signals, you could find out the amplitude that ranges between the minus 100 to 100. Okay, so that's why it's useful for me. Okay, that I will go on doing a filtering and then I'll use the information. So this is what is features, the normalized values of features for gamma band. See the lower end, it's for the normal, sorry. The lower end is for the normal EEG signals, and the upper end is for the epileptic seizure ends. So the same thing that you will be finding out here. Okay, this is for the beta. So this is for abnormality, and the lower one, it's for the normal signals. So if you compare this, these are easily separable, because they are good for me for the classifications, right? Now this is the same thing that is performed with the EMD also, and you can come up with the good things. So with this EMD, we know that this wavelet filtering is a certain fixed range of filtering, okay, and you could come up with a fixed range of frequencies with this. Whereas IMF, EMD is always having an advantage that it is adaptive filtering, and this adaptive will give you the, as per the information you could able to come and separate with the IMF functions. Again, the same feature extractions will be done, feature selection will be done, and feature vector will be constructed. These are the example of 5 IMF I have taken and worked with it. It shows this particular is this is result that I have taken upon a Veka tool. Okay, where you will find out that the features that I have taken for the 3 different classes. Seizure, okay, the EEG signal which is normal with the eyes open. Eyes open stands for there will be certain artifacts. Normal with the eyes closed means no blinking artifact. Okay, so if you compare these 3 classes, you will find out that certain features are differently or they are easily separable. You will find out these features are easily separable. This is not easily separable, but you will find out this is easily separable, right? So this is also one of the way by which you could able to select your features. There is a facility available about a PCA, ICA for feature selections or feature reconstructions in Veka tool. You can definitely use that tool for your analysis. The next thing that is about that is done about this. I'm sorry, I could not see this. This is done, I think, SSAMD, and this is what is done. These are certain SSMD features. SSMD. What happened in case of EMD is that you have IMF that are constructed that is onto the basis of adaptive behavior of the signals, and at one point of time they get overlap. So because of this overlapping feature of the EMD, we have to go with the next what you can say. You might be knowing EMD. That is what we have. And that sort of advancements is made in EMD. So I have proposed a new method, and that is what we call it as a singular spectral empirical mode decomposition, where this overlapping of IMF can be it's already reduced, and because of that I could able to get a good results with the SSEMD. Okay, so these are certain features you can also find out they are separable and is useful for classifier. ANOVA. Now if I plot this box plot, it says that if I am taking a normal PSD, okay, so what we identify by the normal PSD, that every band of the signal, okay, I'm talking about here in this case is alpha, beta, gamma, you'll find out that comes into the same range. Whereas if I'll go with the Seizure signal, I'll find out that this gamma and beta comes into the different range, whereas these bands comes into the different range. That's why instead of using all the 5 bands for my analysis, I could only use for the gamma and beta, and that's why I've reduced these 3 vectors vertically. Right? Try and understand. If I'll take only one feature called mean, what I need to do it is I need to go for the 5 different wavelet coefficients for gamma, beta, alpha, theta, whatever, and I have to analyze them for each of the normal and abnormal category. So because of this ANOVA, I could able to get it that the information that is there in the lower 3 bands is not separable. So not to go with that, the information that I'll go for the separable is about the gamma and beta will have a definitely a different approach as I'll compare these normal. Just give me seconds. So if I'll compare this and this, they are in the same sort of behavior, whereas this and this will be having a different approach of variations. Right? So I'll choose a gamma and beta for my part. So I've reduced with the 3 different coefficients from the part. So this is what is reduction as the dimensionality problem can be solved. We can see that PSD, okay, for the gamma, beta, theta, you will find out the parameters that are separable are for gamma and beta. That's why I can use this gamma, beta for the various features. If I'll go with the Seizure normal, with the eyes open, normal with the eyes closed, and if I'll plot this box plot, what it shows that for the Seizure, you will find out different feature than about the normal. So I'll make this in a range for threshold for normal is this, and beyond that, the threshold for my abnormal is about this, right? So that way it will be the same thing that you can find out for the IMFs. Okay, I have taken a ZCR feature over here to say just justify you that IMF 5 will work for me. Okay, and I've only used a IMF5 for the feature extraction. By doing all this, we could see that I have constructed a feature vector using time frequency domain, wavelet. Okay, then I have analyzed some, added some spectral features over here. Then again, this is wavelet, then EMD with a wavelet, and a final feature vector that I've used is this, right? And thus I could able to get a good accuracy. Before going for the actual result of this seizure detection, I would like to say that by means of ANOVA, I could able to reduce the vertical space of my feature vector, whereas the horizontal space of this can be reduced by means of genetic algorithm by optimizing it. So that's why I have designed a FPGA architecture for genetic algorithm, and the feature vector that you have reduced by ANOVA I have submitted as an input to this architecture, and that will come up with the reduced horizontal features that will be used for the classifier, and because of that it will be improved in a various. So these things is already published. Okay, these are the architecture that is published, and it is used on a Spartan 6. I proved this results with the Spartan 6 and Z board available in the Xilinx. These are the performance parameters. These are very general performance parameters normally used in a signal processing. So these are the features where I'll find out the best feature is with this SSMD. Okay, so sorry, so this is what is SSMD. If you compare the true positive rate and false positive rate, it has a good impact onto the separation of this normal and abnormal. That is what seizure detection. Right now, I'll come down to the topic seizure prediction. Now here in this case, I have more important information for me is timing information, because I have to predict the occurrence of the seizure, right? So I have to come up, my final result is time. Okay, so I have to go on finding out the time by which we can say we could able to identify. That's why I have not used a DWT here. I've used the CWT here, that is what a continuous wavelet transform, and I've used pattern adapted continuous wavelet transform. This gives me a flexibility to select my mother wavelet as per the adaptive behavior of the EEG signal. So you can search pattern adaptive wavelet transform. It's very good thing to go for the CWT with this pattern adaptive wavelet transform. So if you see that timing analysis, it shows that my normal behavior of the patient is like this. I've taken a window of a pre-seizure is earlier to the seizure, and then this is what is the seizure. I've used these features to predict the EEG signals. So same procedure is followed. Okay, that we have, this is what is algorithm for pattern adapted. You will find out anywhere. Okay, now based on to this, again we have find out the features. Okay, we have extracted the features. This is a feature vector constructed. Okay, this is the features that are extracted, and now this is what is the spectral scaleogram that you can have for this. You could see that in pre-seizure what happened. Okay, and in seizure what happened. The same thing you can observe here also. And this information is very useful to identify a pre-seizures, and that is being done. So here this first table shows that simple time and frequency features, and second table shows that after pattern adaptive wavelet transform, whatever wavelet coefficients that we got, we have analyzed on the basis of these features, and this is what is feature vector constructed for it. So you will find out feature 1 is constructed using time and frequency, and feature vector 2 is constructed using a pattern adapted wavelet transform. Now both the information are useful for me, so that's why the combination is made and it's given to the fuzzy classifier. Okay, and by means of thresholds informations, these rules are defined and can come up with a good results. Okay, so this classification accuracy, you could find that it's great, about 96.52 and 95. You might feel that it is not big with this, but what is important in this is just timings. Okay, I could able to get with the 120 seconds, that is 2 minutes ahead of the seizures. You could able to identify that the particular seizure can be there after 2 minutes. That is what is seizure time, and this is outcome of this research, and it's published in a SCI indexed paper already, SCI indexed journal, and you can refer to that. Next, as I said, one more research problem that we can take over here, and that is what is classification of seizures. As I said, you can go in classifying epileptic seizures, okay, in the various classes. Similar way, you can go with the non-epileptic seizures, right? So the methodology that is used is again the same. You can go with the power line removal, noise removal, then artifact removal, then feature extractions, then feature selections. After feature selections, classifications, and you can classify them into the seizures. These are the classes that's abbreviated as FNSZ, GNSZ likewise. So the data set uses TUH, as I said, Temple University Hospital data set. It's a big data set. I've used these only from that. Okay. And empirical wavelet transform is proposed by Dr. Ram Vilas Pachori. You might be knowing him from IIT Indore. He is the godfather of this empirical wavelet transform. So he have already worked on to the seizures and EEG signals. By means of that, I got inspiration and I worked on to the same point. So this is EWT related methodologies. You can get it IF from 0 to 5. And again, you'll go with the feature extraction, selections, and feature vector constructions. After this, I have proposed, as I said, again, this EWT has a separable problem that can be separated, as well as this can remove certain adaptive artifacts also that will be observed. So by means of this SSCWT, which is proposed by me and accepted in one of the Web of Science journal. So this is again, I'll be separating with the IMF, finding the features, and then going with the selections method, feature selection, and then with the feature set construction. I've used random forest classifier for this, which is tree-based classifier, and I could come up with the good results of this. Okay, these are the features that are extracted. Okay, and these are the results. My main consideration is about separating the seizures for non-epileptic and other epileptic seizures. Right, and if I'll go with the only wavelet transform, you could see the accuracy that I'll be getting is 67.1%. Okay, and for tenfold as well as 66 cross validations. Okay, both the way my frequency, my accuracy is very less, so that's why I've used is about EWT. Overall, what you can say, true positive rate or accuracy is increased from 64 to 83. But if you find a false positive rate of EWT in this class for the non-epileptic, it's very high, which is 0.056, that is 56%, which is big enough for the false positive. So that's why I'll go with the SSCWT. Okay, and this SSCWT, you could see that the accuracy that is observed is 91.2% for the non-epileptic seizures with the 0.007 false positive rate. Okay, so that's why this classification, somewhere you will find a very good accuracy for various classes. Okay, and you can go with the good classification accuracy for all the classes. In fact, I am in the interest of the non-epileptic. Okay, so these are the certain results that I got it for EWT. Okay, classification accuracy, if I compare, is already shown in the earlier table. Whereas if I compare singular spectral empirical wavelet transform, it's again proposed by me, and singular spectral empirical mode decomposition is also proposed by me. You could find 94.2% of accuracy is available with the SSEWT, whereas it has 87.6%. This is the overall summary of the work that is done in the area of this epilepsy. So I've used a TUH data set, which will be classifying your data set into 10 classes that is mentioned in the bracket, and can get the good accuracy of 94.9 and with the good improved false positive rate. Right? These are the certain things, what we can say, what we can do it is here. Actually, yeah, these are certain areas where you can take up your brain analysis as one of the research, and you can work in various areas like this. Okay, these are just some examples of the research projects or research work that you can take up. Okay, and we are already working on this. I'm involved in directly or indirectly in the various all of these researches. Okay, so this is what is from my side. So hope I have conveyed sufficient information. Thank you so much. So we can go for questions.
Hello.
Yes,
Good
ma'am.
afternoon, madam. Paitana madam here.
Yes, good afternoon, ma'am.
Yes. So can we proceed for question answer, sir, ma'am?
Yes, ma'am. Yes, ma'am.
Yes. So is this epilepsy condition is 100% curable,
No,
or
it's not 100% curable, because even though you temporarily get a read of this epilepsy, after some age time you can again get suffered by this epilepsy. So it's not fully curable, because some of your brain have started irregularly, and you can only normalize that functions for certain time, not fully for the life. So that can occur after
okay.
some time.
Yes, thank you, ma'am.
Okay.
The next question: can we analyze EEG signal in the form of image for better prediction, better classification result?
Actually, you can definitely do that, because normally people used to do this, that they used to divide a one-dimensional signal into the two-dimensional signals and can work onto the better predictions. But my suggestion is that analysis will not help any patient or doctor. Why? Because they don't have recording of EEG signals in a two-dimension. They have a method of recording EEG signal in one-dimension method. So that even though you will come up with a good solution, that will not be useful to the doctors or patient unless you will not have a machine which will record your signal in a two dimension, or which will convert that one dimension into two dimension. Okay, and this is time dependent signal. So time dependent means continuously you have to convert that EEG signal into two dimensional, and then only information will be useful. Okay, so that is what. Otherwise, you can do any sort of analysis with any data. Hope I'm clear.
Yes. Yes, ma'am. Thank you.
Yeah.
The next question is from Meeta, ma'am.
Uh-huh.
The electrodes used to measure EEG signals are wet or dry?
Okay, so here in this case, you will be the thing that is available is wet also and dry also. Dry will be preferable. Why? Because wet signals are normally used where we need to go on shaving our head, and then we can place them and can do it. Okay, so these are used in a very higher level, sort of like pre-surgery information or surgery information. You can say the regular, what you can say, monitoring, that sort of things, the weight sort of sensors are used. But for the initial identifications or very frequent measuring of EEG, the dry sort of sensors are used. Okay, so that depends actually where you are going to measure this. And for my data set, these are scalp data set, which is dry sort of things. For the CHB, MIT and TUH, these are all dry. Whereas for Amit Kumar Pandey's data set, some of them from the dry and some of them are from the wet sort of sources. But that will not,
Yes.
basically strength of sensors, they have good, what you can say, compensation in dry and wet. So I don't think so key information will be much hampered because of the selection of dry or wet.
Yes, thank you, ma'am.
Yes.
The next question, why classifiers fails on practical data?
Correct. It's a very good question. Why it fails on because I have faced it while working on a real-time data set. Basically, when we are looking forward for classifiers are trained onto certain data set. So they have a limited information of training. And when you go on a real-time data set, okay, I have said that I have referred only 20 patients, right? And if I am looking for EEG signals, every individual has a different EEG pattern, okay, and that's why that information is not fed to my classifier. So if it is not fed to my classifier will fail. And that is what is limitations of these kind of random signals or non-stationary signals. It cannot come up with 100% accuracy, even though you have come up with 100% accuracy with the standard data sets. So training is the problem. It should have adaptive training. That means I should read any EEG signals. I have to train my classifier adaptively, and then I can use it for the classifications. अगर ऐसे हो सकता है, तो then in that case classifier will not fail much.
Okay, thank you, ma'am. The next question is related to prediction time. So what is the practical prediction time possible? Means how, at what level we have achieved?
Okay, for me, I have achieved with the 120 seconds ahead of the Caesars. But this is when this again, as I said, it's very limited to what data set that I have used. I have not tried with the real time data set. I'll clearly say I have only tried with the standard data sets and that can come up, but that will improve. You can improve that. Agar, if you'll go on identifying distinct features onto the pre-Caesar time, you can definitely go on an improvement of this time. And very recently, I think last month only, I could able to get that some 12 minutes ahead of that AG. That paper have claimed about a 12 minutes of ahead of ahead of Caesar. He could able to identify that Caesar. That will be that's I think Parvez is the author for that. Parvez something. So you can follow him also. He's also doing a very good work in the prediction of the Caesars.
Yes, ma'am. Thank you. Early detection of seizure attack. So how much period that we can say early detection?
It's the
So
same.
that
The
person
answer
will get
is the
ready.
same. No, see, basically, the same answer that I've given earlier is the same. That is, initially, like there is not many research is going in this area that where the alert time can increase. That is very earlier to the occurrence. If you could get come up, we can provide a good solution. But in that case, there is not much research. There's still research is going on. As I said, 12 minutes is a higher thing that I have read through. It might be more than that.
Yes, thank you, ma'am. So this was the last question.
Okay, ma'am.
So
Thank
with
you.
this, we are concluding question answer session. Thank you very much, ma'am, for
Thank you so
accepting the
much.
invitation.
Thank you. It's a pleasure being discussing this research in this area, and I really would like to promote that in a neurological disorders. Here, after also, I'm working in the same area. It's a very good area to work on. Okay, so I insist. I invite all the people that choose this, take this particular points as research points, and should work in this area. So thank you, RSCOE, Rajarshi College of Engineering, and AICT for giving me this opportunity. So thank you so much.
Thank you, ma'am, for sharing your valuable information about your research work. Thank you very much. Also, you have detailed the research gap here also. Thank you very much. Thank you, ma'am.
Thank you, ma'am.
So participants, we are now proceeding for lunch break. So after lunch break, we will join the next session. Thank you.
Thank you, ma'am.
So,
The next session will start at 2 p.m. So please join at 1:55. Thank you.